Bonjour, bienvenue, bonjour à tous.
Thank you very much,
D'abord, je
Audrey.
voudrais remercier
Good
justement
afternoon.
l'équipe ELA
Welcome. I'd
internationale
like to
pour
thank
l'organisation de
the
ce
ELA
meeting.
International team for having
Plus
organized this
particulièrement Jean-Luc
meeting,
Corti, secrétaire
and
général,
more
et Audrey,
specifically Jean-Luc
forcément
Coty, the
Audrey,
General
notre
Secretary,
nouvelle
and Audrey
responsable
Boyer,
pour la
our new
recherche. L'équipe d'ELA France,
team
en
member
particulier Eva
in
Eva
charge of
Pierra,
the
Pierra,
research
notre responsable
team, the
administration
ELA France and Eva
technique et
Pira
IT, et
team,
l'équipe
who are in
d'interprètes
charge of the
coordonnée
technical
par Isabelle Brousset,
administration and IT,
Nathalie de la
and the
société
interpreters
Pour
team
Parler, avec
coordinated by
lesquels nous avons
Isabelle
beaucoup
Brousset,
collaboré
who
depuis plusieurs années
chairs
maintenant.
the company called Pour Parler, with
Je
whom we've been
souhaite
collaborating for several years.
également
I would also like
remercier
to
très
thank,
chaleureusement les
from the bottom
médecins,
of my heart,
les
all the
chercheurs qui ont
doctors,
accepté
all the
d'intervenir ce
scientists and
week-end,
researchers who
mais
have
pas seulement
agreed
ce week-end, parce
to
que
take the
je les
floor
remercie aussi
this
pour les
weekend.
efforts
But not just this weekend. I
cumulés de
really would
recherche et
like
de
to thank them
soins
for
apportés
all the
tout
efforts
au long de
that have
l'année
gone into research
à la
and
communauté
the
des
care they
patients au
have
sein de
given
cette
throughout the year to our community
initiative.
of patients.
Alors, on ne
Thank you
s'arrête
very
pas,
much.
nous, à ELA
Now, we
International, à
don't limit
remercier
ourselves to
mais
thanking
aussi
people at ELA
publiquement leurs
International. We also
recherches.
want to
En
support their
2023, par
research.
exemple,
In
ELA International a
2023, ELA
décidé de consacrer
International
1,3
dedicated
million d'euros à
1.3
ses
million
recherches
euros to
sur 7
research on
leucodystrophies
7
ultra rares, dont
ultra-rare
4 nouvelles
leukodystrophies,
pour ne laisser
from
personne
which
sur le
we
bord
have
du chemin.
4 new
Et nous
diseases
prévoyons de
to make
doubler
sure
le
that nobody
financement
is
en
left
2024.
uncared for. And we are going to
Depuis la
double the
création
funding
d'ELA
in
International en
2024.
2015,
Since ELA was
nous avons
created
étudié et
in
fait progresser la
2015, we have
connaissance sur
studied
20 formes de leucodystrophie
the
différentes.
disease, and we have
Et depuis
improved knowledge
la
on 20
création d'ELA
forms of
France en
different leukodystrophies.
1992,
And ever since ELA France was created in
48,8
1992,
millions d'euros ont été investis
48.8
dans la
million
recherche
euros were
médicale,
invested
ce
in
qui
medical
correspond au
research,
financement de
which
571
is
programmes.
approximately
Ce
the
qui fait d'ELA
funding
le
for
premier financeur
571
associatif de la
programs, which means
recherche
that ELA
sur les
is in first
leucodystrophies.
position as an
En
association for
2023
funding on
toujours,
leukodystrophy
nous avons
research.
créé un
In
comité d'éthique.
2023, we created an
ELA
ethics committee.
International a décidé de mettre en place ce
ELA
comité
International
pour
decided to
réfléchir aux
set up this
sujets très
committee to think
actuels
about
comme le
very
dépistage des
hot topics such
leukodystrophies
as
à la naissance,
leukodystrophy
si vous
screening
préférez le
at
dépistage
birth,
néonatal,
also called
l'accès aux
neonatal
nouveaux
screening,
traitements ou
access
encore
to new
comment mieux
therapies,
associer les patients
or
dans la
how
recherche
to
clinique.
better involve the patients in
Notre
clinical
but est
research.
d'identifier les
Our
valeurs sur
goal
lesquelles
is to identify the
l'association peut
values
s'appuyer pour
that the
garantir au
association may
mieux
rely on to
l'intérêt des
guarantee
patients et des
that we
familles.
care for the
Le
patients and the
comité
family's
inclut
interests.
11 membres,
There
des
are 11
représentants des
members in the
familles ELA
committee,
de plusieurs pays
people
européens,
representing the
des
ELA
experts de
families from
l'éthique,
several European
du
countries,
droit,
ethics
des sciences
experts,
humaines, dirigeants d'un laboratoire et des
legal
scientifiques.
experts, human
Favorisant
science
ainsi un
experts,
travail
and people
collégial
who are
et
chairing laboratories and
pluridisciplinaire.
researchers, and
Cette
therefore we
diversité
work in a
assure une réflexion
multidisciplinary team.
équilibrée
And
lors de
because of this,
l'évaluation des
we
questions
have a
éthiques.
well-balanced
Enfin, les
discussion
réunions du
when we
comité
assess
d'éthique
ethics
sont
issues,
présidées par le professeur
ethics-related
Grégoire
issues.
Moutel,
And the
expert des
ethics
questions
committee
éthiques au
meetings are
CHU Caen
chaired
en
by
France.
Professor Grégoire Moutel,
Prenons
who's an expert
l'exemple
in ethics issues
du thème
at
étudié par
the
le
Caen
comité, le
Teaching
dépistage
Hospital.
néonatal de
For instance,
l'épilepsie.
first example,
Comme vous le
neonatal
savez, de nouveaux, je sais
screening.
d'ailleurs
As you
que
probably know,
Stéphane Kep va nous en parler pour
and Stefan
ELA.
Kemp is going to tell
Vous
us about
savez,
this.
comme vous le
So, as
savez,
you
de nouveaux
probably know,
traitements approuvés
new
par
therapies have been
les agences
recently
des
approved
médicaments
by
arrivent sur le
drug
marché chez les
agencies
différents
and are
EHA,
now
tels que
being
le leukodystrophe
launched on the market,
cérébrale,
such as
le
Skysona for
Limeldi pour la
ALD or
leukodystrophie
Limeldi
métachomatique.
for
Mais ne sont
metachromatic
pas forcément
leukodystrophy,
accessibles aux patients,
but they're not
soit
necessarily
parce qu'ils ne sont
accessible
pas
to the
encore
patients,
remboursés,
either because they're not
soit
being
parce que la maladie
reimbursed
est
by the
trop
Social
avancée
Security, or
pour
because
espérer une
the disease
efficacité
is too far
directe du
advanced for
médicament.
the drug to be
Or,
efficient.
pour être efficace, ces
In
traitements
order
doivent
to be
être
efficient, these
administrés
therapies must
générataux
be
avant même
administered very
l'apparition
early
des
on,
premiers
even
symptômes.
before the first symptoms
La
appear.
solution pour ces
So
leukodystrophies est
the
évidemment de
solution
dépister à la
for
naissance.
leukodystrophies would
Mais
be
obtenir un tel
screening
dépistage
babies
à
at
l'échelle de
birth.
tout un pays
However,
ne va pas de soi,
obtaining the
et ce
whole
n'est pas une
country
question de coût qui
to
reste
perform a
relativement
screening at
désuète.
birth is not
Le
obvious.
comité
It's not
d'éthique
so much a
décide
matter of
réfléchir
cost
tout
because
au
it's
long de
relatively
l'année
cheap. It's
2023 avec
the
l'apport de
problem lies
nombreux
elsewhere.
experts
The
et de
ethics committee has
communication.
been
Il a
working
rendu
on
un
this
avis très favorable
issue
sur le
throughout
dépistage
2023
néonatal
and
sur les
has
leukodystrophies
published
DNN et
extensively,
leukodystrophie
giving a
métachomatique.
favorable opinion
Nous
for
disposons aujourd'hui
DNN, for
d'un
ALD, and
argumentaire
MLD.
solide
And we
pour
now
financer
have
ce
DNN
dispositif
being
de santé avec les efforts évidemment soutenus
screening
par
at
les
birth, and we
autorisations
now have
nécessaires pour ce
solid
dépistage.
arguments
Nous avons bien
to
conscience
introduce to the
que
health
tout cela
authorities, and
prend
we
du
hope
temps,
that we're going to
beaucoup
win.
de temps.
We are aware that
Mais si
this
on veut que
takes
ça change,
time.
il
It's
faut
very
se
time
rassembler,
consuming, but if we
il
want things
faut
to change, we have
s'investir.
to work together. We
Alors,
have
ça
to
c'est un
be
message plus
committed.
personnel aux
Now, this is
familles et
my
pour les
personal
patients.
message for the families.
Vous pouvez déjà faire une chose
I
relativement
think you can
simple.
also do
Si vous
something
n'êtes pas
already
inscrit,
on
c'est
your
de vous
level.
inscrire sur le Connect.
You can log into LuConnect, register for LuConnect. In 2015, when we created ELA International, there were two major aims: pooling our financial resources for research, and bringing the patients together on the whole planet. This is absolutely essential to accelerate treatment discovery. And this is why we decided to create a LuConnect, an international clinical research platform, bringing together all the ELA families. So don't wait any longer. Register on the www.luconnect.com platform. It's time, honestly, it's time now to join us on this platform so that we can together create a force which is absolutely essential for our therapeutic progress. Before I give the floor to the first speaker, Stefan Kempt, as the chairman of the next workshop, I would like to repeat how much I respect and admire the patients whose children are sick, the families, the relatives, for their testimonies and for their resilience. Because you're in first line, you, the families, you are speaking for your patients. You are ELA's strength. And believe me, in the fight against leukodystrophies, you're irreplaceable. You have to play this role. Thank you very much for your attention. I wish you all a very fruitful 2024 symposium and a very nice weekend. And now, Stefan, you have the floor. Thank you.
Thank you, Guy. Thank you for the very kind words. I think we'll probably have to change the language. I can only wholeheartedly say that it's really a pleasure and an honor again to be invited to present at the ELA conference. Personally, for our research in the Netherlands for ALD, ELA has been incredibly important. I can tell that without ELA, there may likely not have been an ALD research group in Amsterdam. So yeah, always thank you, and yeah, I really am very happy to present here on ALD newborn screening. And okay, now the first challenge is see if I can share my screen, and if that all works. And please, anybody tell me if it works. Oh, dear.
Yeah, it's good.
Ah, thank you. Okay, so yeah, I will start off this afternoon with presenting on ALD newborn screening. I will do a very brief introduction on ALD, just very brief. These are my disclosures for this talk. The study, the ALD newborn screening study, was funded by the Dutch Ministry of Health, Welfare and Sport, and by Soumeya BEKRI. So very briefly, adrenoleukodystrophy, or ALD, is a rare disease that affects about 1 in 15,000 newborns, and these are men and women combined. So it's a rare disease, but if you calculate the number of babies born each year in Europe alone, that amounts up to 350 new patients each year. So even though it's rare, this is a very high number. The disease is caused by mutations, or as we say nowadays, pathogenic variants in the ABCD1 gene. And this gene is located on the X chromosome. So adrenoleukodystrophy is an X-linked disorder. And the disease affects the brain, the spinal cord, the adrenal cortex, and the testis. As I said, it's an X-linked disease, and it's always good to realize how the mode of inheritance works for an X-linked disease. So in case the mother carries the defective gene, so here shown in blue, so she is a heterozygous for the disease. So in each children, she passes on one of the X chromosomes, and that means that if she gets a daughter, the daughter has a 50% chance of having ALD. And similar, if she has a son, there's a 50% chance that the son has ALD. And this is, of course, for every new child. If the father has the disease, he always passes on his Y chromosome to his sons. So none of his sons will receive the X chromosome with the mutated ABCD1 gene. But if he has a daughter, he can only give his X chromosome with the ABCD1 mutation. So all his daughters will be carrier or will have ALD. So ALD can be diagnosed at birth. So at birth, all ALD patients have elevated very long chain fatty acids, and I will not go into the biochemistry of the disease, but this is the clinical or the biochemical marker of ALD, and all patients will have a mutation in the ABCD1 gene. So this we can predict, and this we can measure, and this we can determine. But what we cannot determine, and this has been a challenge for us ever since the ALD gene was identified, is that we cannot predict the clinical outcome of individual patients. Males are at high risk of developing adrenal insufficiency. And now that we have newborn screening, the youngest patients that have been described, boys having the adrenal insufficiency, are 6 months of age. From the age of 3 years onward, males are at risk of developing cerebral ALD, also called leukodystrophy. This is an inflammatory reaction in the brain. And in adulthood, virtually all males and more than 80% of the women with ALD will develop a slowly progressive spinal cord disease. If we break down these 3 core diseases or outcomes in ALD, we get a very complicated graph. Here we're shown the three symptoms. But if we break this down to the age of 10 years, there's some very important message here. So we see the blue line, and the blue line is the adrenal insufficiency. And what this graph shows you is that 1 out of 2 boys will develop adrenal disease before the age of 10 years. The good thing about adrenal disease is that it can be treated very well by hormone replacement therapy. But if it's not treated, it can result in severe morbidity, and children who are not recognized and treated for adrenal disease can end up in the hospital. If we follow the red line, we see that 1 out of 2 boys will develop the brain disease, the leukodystrophy. And also for this form of the disease, there is a treatment, a bone marrow transplant. But this is only effective before clinical symptoms of ALD are visible, because then the lesions, so the inflammatory reaction in the brain is still small. So what this graph tells us, that basically very simple, if we can diagnose ALD at birth, we can follow the patients in their disease process, and we can monitor them. And in case either adrenal disease starts or the brain disease becomes visible, there's still time to start treatment. And this was already recognized by Hugo Moser in 2004 at a newborn screening conference in the United States, where he said that ALD newborn screening would save lives. So everybody agreed, but at that time it was not possible to diagnose the disease at birth, because for that you need a high throughput method, and the very long chain fatty acid analysis in plasma is not high throughput. In 2007, C26 lysophosphatidyl-choline, or C26-lyso-PC, was identified as a very powerful biomarker that's elevated in newborn Huprick blood. And the nice thing about this biomarker is that you can rapidly analyze it with tandem mass spectrometry. And from that time on, it was possible to develop a high throughput method. And that you need if you have to analyze the blood of hundreds of babies every day. But it took another 6 or 7 years before ALD newborn screening was started. And for that, we have to credit Elisa Seeger. Elisa Seeger still lost her son, Aiden, to cerebral ALD because he was diagnosed too late. And then once he found out that it was possible to screen babies at birth, she motivated people in New York State. And in 2013, Aiden's law was passed. And by that, New York State started initiated newborn screening for ALD on December 30th of 2013. And also importantly, in the United States in 2016, ALD was added to the recommended uniform screening panel list. This is a list of conditions that fulfill the criteria of newborn screening. So this is the current situation in the United States. More than 40 states are screening for ALD. And at this current moment, more than 93% of newborns are screened for ALD. Let's move outside the US. So in 2016, Taiwan started ALD newborn screening. And in 2021, regional pilots started in Israel, Italy, and in Japan. And in 2022, a regional pilot started in Spain. Now I'd like to move to the Netherlands. In 2013, my colleague Mark Engelen and we nominated ALD because we heard that the Dutch Health Council had plans to expand the newborn screening program in the Netherlands. And in 2015, the Dutch Health Council published recommendations to the Minister of Health to expand the Dutch newborn screening program with 14 additional diseases, and one of these was ALD. But there was an interesting discussion ongoing in the Health Council, and that relates back to the Wilson and Younger criteria for newborn screening, because these are criteria that were already put forward by the World Health Organization in 1968. And one of the most important points is that early diagnosis must be directly beneficial for the neonate. So there must be a treatment for the baby. And this is translated from the Dutch Health Council report. And it says that screening for ALD is only useful for male newborns because the symptoms in women usually arise later and cannot be treated. So there's a very low percentage of women that develop cerebral ALD or adrenal insufficiency. And in adulthood, they develop spinal cord disease, and for that there is no treatment. And it is also an adult onset disease. So this is not in the neonatal period. Therefore, the committee recommends to only screen male newborns for ALD in the newborn screening program. And we have an interesting situation because in the United States, in Taiwan, in Israel, Italy, and Spain, all newborns, so both boys and girls, are screened for ALD. And in Japan and the Netherlands, only boys would be screened for ALD. And I gave this a lot of thought, and I've been in a lot of discussions with families and with physicians and ethical people about why is this so different between different countries for ALD. And we have here a table of two views. The medical ethical perspective to only screen boys, and the ALD perspective to screen boys and girls. And from a medical ethical perspective, so from the World Health Organization, girls do not fulfill the criteria for newborn screening because they develop myelopathy, the spinal cord disease, in adulthood, and there's no therapy for that. So by diagnosing a girl with ALD, you basically have a patient in waiting due to the late onset of the disease. And there's the burden of knowledge and the child's right to an open future. And knowing that you eventually are likely will develop a disease, it may have a negative impact on the quality of life. It probably has financial consequences. And for the parents, there's the loss of the happy or the golden years, knowing that your child has an untreatable condition. However, from the other perspective, the ALD perspective, there's enough reasons to screen both boys and girls, because early disease awareness, it creates early disease awareness, and a girl can anticipate for future health problems. For the family, the identification of an affected girl enables extended family screening, and there are many examples where extended family screening diagnosed boys or picked up boys who were not yet diagnosed with ALD, but who had the diagnosis, and they could follow up the treatment protocols. And it's, of course, it shortens the time to diagnosis, also referred to as the diagnostic odyssey, when symptoms arise. And parents can make informed decisions regarding family planning. And another argument is that if the girl becomes a woman of maternal age, she can make informed decisions. I think nowadays I say there is no good and right, or good and bad in these decisions. And I think the only not good decision is not to screen for ALD. And so either you choose one program or the other program. I think it's just screen. That's the most important. But the challenge we had is that sex-specific newborn screening does not exist or did not exist in any newborn screening program worldwide. So we did not have an example. And therefore, a pilot study had to be initiated, and that became the SCAN study. And that was funded by the Dutch Health Council, or the Dutch Ministry of Health. And this is a map of the Netherlands, of the 12 provinces and the Dutch Caribbean islands here on the other side. And the Netherlands is divided in 5 newborn screening regions, here indicated by the 5 different colors. And each of these regions have a newborn screening lab. In the pilot, the SCAN study, in which we had to develop and test the boys-only algorithm, 2 of the screening labs and 2 of the regions participated. And the pilot would last for 1 year, and we know that in those 4 provinces, in about a year, around 70,000 newborns will be born. So the task that we had was to design, develop, and validate a screening algorithm that identifies males by only using the dry blood spot. And we were not allowed to identify unwanted findings or untreatable diseases. And if you think of an X-linked disease, you can pick up Klinefelter syndrome, Turner syndrome. And if you think of the C26 lyso-PC, it's very sensitive for ALD, but it's not specific. Other diseases like Zellweger, ACOX1, and some other diseases, you can also identify with C26 lyso-PC, and we were not allowed to identify those. And for this, we only had, so this is a dry blood spot, and this is 1 punch of 3.2 millimeter, and that is all we had. And we bargained, and we could receive 2 of these punches, but this was all we had to set up this screening. And we had a long discussion about how would we pick up boys, and eventually we came up with a rather simple way, and that is make use of the autosomes and the sex-linked chromosomes, and I will show that. For example, here we have chromosome 3, and we have 2 chromosomes 3, but males only have 1 X chromosome. There's a 2-to-1 ratio of the autosome or chromosome 3 to the X chromosome. And in women, there are 3 chromosomes 3 and there are 2 X chromosomes. So the ratio is 1-to-1. And with laboratory techniques, you can visualize this as shown here. So you can with this test you can identify individuals with 1 X chromosome. And the nice thing about this test is that it has 3 of these tests, so which increases the sensitivity of the test. So this we use this test, and we place this in the algorithm that was already developed by New York State, which is shown here. It's a 3-step algorithm. We placed our X counter, as we call it, as the second tier. So what happens is that the blood spot is taken from the baby, it's sent to the laboratory, and then the C26 lyso-PC is measured. It's very rapid, but it's not so sensitive. So there's a high chance of false positives, but we can use this to limit the number of samples that have to be screened by the X counter, which takes much more time. So if there's 1 X chromosome, the sample continues to again measure C26 lyso-PC, and now the little longer taking analysis, but much more specific. If it's again above the cutoff, so screen positive, then we sequence the ABCD1 gene. If there's a variant in the ABCD1 gene, a pathogenic variant, then we very likely have a boy with ALD, and this boy is referred. So we have a 4-tier program in which 4 different labs were involved, and we have to finish we have to finish this process within 35 days, because 35 days after birth, parents will receive a notification of the screening results. And of course, if there's a metabolic disease, they will know this very earlier on, but they always get a message. It's a pilot, it's a study, so parents were asked to give informed consent. And of course, we had to test this boys-only algorithm, so we also asked parents of a girl if they wanted to participate in the trial. We also built a website for information. And the study is over, so I can now show you the results. As anticipated, more than 70,000 babies were born in these 4 provinces. Out of these, almost 1,200 declined to participate. The participation rate in the Netherlands for newborn screening is very high, over 99%. And in the pilots, almost 99% of the boys were screened for ALD. So we did tier 1 in 71,208 newborn blood spots. And before we started, so these are the results from the C26 lyso-PC measurement. And before we started, we had set up a cutoff. So everything that was above or equal or above 0.32 micromolar was screen positive. So these samples here, they were screen positive and they were sent to the X counter. And throughout the year, that were 507. In the X counter, we measured the X chromosomes. We had a nice 50-50 ratio between girls and boys. But only the samples with 1X, they went to the third tier, which again was the C26 lyso-PC. Before we started, we had validated this method. So this is on the left in green, you see in blue, you see the samples before we were screening babies. So just to validate the method. And on the right, we see the results from the screening. And there were 20 samples that were above the cutoff that we have set. And these went to the fourth tier, and that's the sequencing of the ABCD1 gene. And the results are shown in this table. So there were 20 males. In 16 cases, there was no variant in the ABCD1 gene, so we stopped. And in 4 boys, there was a variant in the ABCD1 gene. And these boys, and these families, they were referred to the pediatric neurologist. This is the complicated but very effective newborn screening system in the Netherlands. So now we have passed all these numbers here, and now we are here at number 8. So there's a signal that there is a positive newborn screening, in this case for ALD. So what we set out to do is that before the family is notified, already an appointment is scheduled at the Amsterdam Leukodystrophy Center. Then next is that the medical advisor contacts the family physician, because in the Netherlands it's the family physician that contacts the family. And we have decided to do this not on a Friday, because we don't want Dr. Google over the weekend interfering with this whole process. So in the pilot, in all 4 cases, it was on a Tuesday. And then on Wednesday, the family already met with the pediatric neurologist. So now we're here. We have a positive newborn screening result. The family meets on the next day with the pediatric neurologist. In all cases, it was my colleague Mark Engelen. Of course, Mark draws some blood to confirm that the right baby ended up in the hospital. If that result comes back, that's a few weeks later. The family comes back, and then already in the morning, a blood sample is taken to test the adrenal function. They also meet with the clinical geneticist to make the family tree to see if there are other children at risk in the family. And this process continues every 6 months. So every 6 months, a blood sample is taken for adrenal function. And when the boy reaches the age of 2, he will get his first MRI, and that will occur every 6 months until the age of 12 years, and then every year. Because we had a lot of information anonymized, we could also ask one of the other important questions: what to do with a premature baby? Should that baby be rescreened at a term age? And so we looked at gestational age and the C26 lyso-PC, and then if we compare that to ALD boys, we see that there's a clear separation, and the important message is that a premature newborn does not have to be rescreened for ALD at term age. Well, to summarize, we know that these are the yellow ones are the ALD boys. They have normal gestational age. They have a normal birth weight. So everything looked really good. We made a report, and it was positively accepted by the Ministry of Health, and as a result, the Netherlands started screening for ALD last year, October 1st. So now we are like almost half a year underway. But a little reality check. This is the timeline going from nomination in 2013 to live screening. It took us almost 10 years to go through all these steps. And now just a few more slides on ALD and newborn screening in Europe. So this is a map of Europe with the current ALD newborn screening in Europe. So the Netherlands is the country where the screening is now nationwide. In both Italy and in Spain, there are regional pilots are ongoing. And I know that in England, in France, in Switzerland, in Germany, and in Hungary, mobilizing efforts are ongoing. Also, as what Guy mentioned, yeah. So there are enough reasons to do that, and now you have to try to get ALD in the National Newborn Screening Program. I also mentioned that in the United States there is the RUSP list, so the list of diseases, conditions that fulfill the newborn screening criteria. This is very different in Europe. This is an overview of the conditions that are included in the different newborn screening panels across the European countries. This looks very complicated because here are all the diseases and here are the countries, but I also made a graph of this. Some countries, or many countries, screen for less than 10 conditions, or sometimes even less than 5, and some screen for more than 30, and Italy is screens for the most conditions, currently for 46 diseases, and if my information is correct, there are another 14 diseases or conditions that are maybe added to the screening panel this year. So that brings me to my last slide. So one of the problems in Europe is that there's no harmonization among European countries. We don't have a RUSP list in Europe. So there's little agreement which disorders should be included in the newborn screening program. And some countries screen only for 2 diseases, while others screen for more than 13 conditions. And I think that really would need some attention in Europe, to see if we can find ways to align this among between countries. So what we showed is that male newborns with ALD can be identified by just using these 3.2 millimeter blood spots. The algorithm that we developed is in compliance with the Health Council's recommendation to only screen boys for ALD. We show that gestational age, sex, birth weight, and the age of blood sampling have no effect on C20 lysis PC. The Netherlands started nationwide screening October last year. And yeah, as I said earlier on, whether you screen only boys or boys and girls, I think the most important is to screen for ALD. And the fact that we had now designed a boys only algorithm, together with the fact that different stakeholders have different views, now we have two ways of screening for ALD. So this argument cannot longer be used to not screen for ALD. So I hope this speeds up newborn screening across Europe. These are all the people who are important and involved in this project. And then I will stop sharing. And I'll give the floor back to, I think, myself as a chairman. Then with that, I would like to introduce or give the floor to my colleague Florian Eichler from Mass General Hospital in Boston. Florian has been the PI on many projects. One of which gene therapy, the other one AAV gene therapy. He was one of the founders of ALD Connect. And Florian, I give the floor to you, and if you can start sharing your slides. Yeah. Yes, they're also in presenting mode. The floor is yours.
Okay. Can everybody see my slides? Yes? Okay, great. Thank you, Stefan. Always great to hear you, and I always learn more, so I look forward to the discussion. I have a few questions, but I just wanted to, as Stefan said, briefly speak a few words about the current status of ex vivo gene therapy for childhood cerebral adrenoleukodystrophy. Here are my relevant disclosures, some co-PI of this gene therapy trial that's now completed, and PI of several other gene therapy trials and founder of Swan Bio. Before I talk about ex vivo gene therapy and its current status and benefits and risks, I want to highlight the fact that when we speak of gene therapy and approaches to gene therapy, we're not talking about one single approach. gene therapy really can be conducted in different ways. The in vivo gene therapy that currently is not yet approved in leukodystrophies is an AAV-mediated gene therapy that is used for spinal muscular atrophy and other conditions. This is a direct delivery of a transgene to a target organ. And different from that is what we call ex vivo gene therapy that I'll be highlighting, which is based on the fact that we harvest cells from the patient and then transfect those cells with a different virus called a lentivirus, and then give those cells back to the patient. Hence, this is called ex vivo, or outside the body, because outside of the body is where the transfection occurs. I will not highlight other modalities here today. As I said, there are really two different viruses involved in the gene therapies I outlined. Adeno-associated virus is a small DNA virus, and the lentivirus is a larger RNA virus, almost twice the size. Hence, you can package larger transgenes. There's more room for the product inside the lentivirus. But importantly, the delivery is different. The adeno-associated virus can be injected directly into the brain, or it can be injected into the intrathecal space, so the space of the similar to a lumbar puncture. Different from that, the lentiviral delivery to cells. These cells go to bone marrow, and then from bone marrow they go to blood, and from blood to brain. When they integrate into the bone marrow, something happens that we call hematopoietic reconstitution. That essentially means that you have now a lifelong source for corrected protein in the cells that have engrafted and are giving rise to new progenitor cells. Okay, I don't need to go into this in detail since Stefan already spoke to this. This is just to highlight that adrenoleukodystrophy is a single gene disorder that can have different manifestations. This gene encodes a protein called ABCD1, used to be known as ALD protein, and this is important for transporting very long chain fatty acids into the peroxisome. We know of different manifestations: the brain inflammation called childhood cerebral ALD, the spinal cord degeneration called adrenomyeloneuropathy. So the gene therapy I'll be highlighting is going to be for childhood cerebral ALD. So just to connect to what Stefan just said, newborn screening has really been a game changer in our field. And the reason I'm highlighting this in the US for our trial, I do not think we would have been able to make the progress and complete these trials so successfully without newborn screening. It really allowed us to move very quickly and have a monitoring in place to detect these boys before they were symptomatic, as ALBA said, at the stage when they were having first small lesions in the brain. And this map shows the current status of newborn screening in the US. You can see that the vast majority of states have implemented newborn screening. Just a few more states still holding out or in pilot phases. So how does childhood cerebral ALD progress? This is important to understand regarding trial for gene therapy. Please note that when you have a lesion in the brain. It usually starts in the center of the white matter in an area we call the splenium of the corpus callosum. Then it spreads outward and spreads symmetrically and in a confluent fashion and takes over the entire white matter over time. Important that these changes on MRI precede the symptom appearance. And so you can see these MRI changes before there are changes in language or changes in gait. And I always tell the parents not to worry about any changes in attention or hyperactivity in a child with a normal appearing brain. Every child at this age has some developmentally normal changes in attention and behavior. So how do we measure the neurologic progression? By clinical symptom description, we use a neurological function score. This encompasses 15 different domains, and we highlight here the major functional disabilities in bold as the 6 most serious symptoms: loss of communication, blindness, tube feeding, wheelchair dependence, total incontinence. Notice here that the more symptomatic the child, the higher the score, with a total of 25 points being possible. How do we measure the MRI changes? We use something called the less MRI severity score. This measures the extent and degree of white matter changes across different regions of the brain. You can see here less score of 1 with only the center of the splenium affected, and here less score 15 with much more extensive white matter changes. Important to note that in the active inflammatory stage of the disease, there's a garland of contrast enhancement around the white matter lesion, showing us that this is active and progressing. The MRI really corresponds directly to the pathology on brain. And there's a similar zonal pathology, meaning in the center of the brain lesion, usually there's a burnt out necrotic core, and then there are areas here in B and C where you can see an area that usually shows contrast enhancement, having a lot of perivascular inflammatory cells. But the most interesting part is what happens beyond in this zone C, where you see microglial cell loss and microglia that look very angry and unhealthy, and you can find a band of dead microglia along the rim of this lesion. This is important because we think it's critical to the only modality that had been in place for about 20 years, and that was bone marrow transplantation. Bone marrow transplantation, we knew, could rescue these boys if they were detected in the early stages of cerebral ALD and a donor was well matched. And you can see the differences here between treated boys versus the untreated ones. And we think this is because this zone of microglial cell loss is key. Microglia are really the only cells in the brain that are known to have turnover from the bone marrow. And we think how bone marrow transplantation helps here is that bone marrow-derived monocytes enter the brain and differentiate into microglia-like cells expressing now normal, healthy ABCD1. So the downside to bone marrow transplantation is that you have engraftment problems and you have graft versus host disease. So we thought, how can we prevent this? And we were very lucky that Patrick Aubourg and Nathalie Cartier had done seminal pioneering work in Paris to address this. And they had found 2 boys where there was no available well-matched donor, and they used the boy's own cells to deliver a healthy copy of the gene. And so we are building here on this approach in the trial that we conducted. And just to outline how this works, if you see a boy with inflammation in the brain, meaning there's a lesion and there's contrast enhancement, you harvest the bone marrow cells, select out the CD34 cells, transduce with a lentiviral vector, delivering a healthy copy of ABCD1. You deliver the cells back after brief conditioning with either busulfan cyclophosphamide or busulfan fludarabine, and these follow these boys for a 2-year period. This is exactly identical to what I just showed you before, which is allogeneic bone marrow transplantation, with the exception that these are cells from the boys themselves. So we're using really an autologous approach. So this was first published in the New England Journal 2017 on the first 17 boys that went into this trial. At 2 years of age, 88% of them were alive with no major functional disabilities. However, 2 patients died, one from disease progression that began during the pre-transplantation conditioning, and another withdrew from the study and died from complications of bone marrow transplantation. We've since continued both 2 different trials, one called ALD 102, the other 104. The difference is that one of these trials uses cyclophosphamide, the other fludarabine, and there's been a combined population of 67 patients in both of these trials. So what was the long-term efficacy and safety of ex vivo gene therapy? And you see analysis of these 67 patients in terms of the MRI less score I described earlier. The less score either stabilized immediately or within a 12 to 24 month period. You can see that there were these individual boys who already, this one who was progressing rapidly at the time of transplantation I mentioned earlier. This corresponded also to the neurologic function score. Remember, this was a 25-point scale. With the higher the points, the more impaired the boys. And again here, 94% achieved stable neurologic function without major functional disabilities. So just to highlight the important role that Europe and the group in Paris played in terms of establishing this gene therapy. The first successful bone marrow transplant was performed by Patrick Aubourg, and Nathalie Katia and him also performed the first pioneering studies reporting 2 boys receiving ex vivo gene therapy. And we were lucky to build on this with the first trial that we launched in Boston with Boston Children's and Christy Duncan and David Williams. I will say there have been many ups and downs over the years, and just to highlight that despite EMA recommending commercial marketing approval, Bluebird Bio exited Europe, leaving many of these families in Europe without access to treatment. So that was a big setback and needs to be acknowledged. Further setbacks that we experienced have been cases of myelodysplastic syndrome, here abbreviated as MDS, first detected in the summer of 2021. So these were difficult days, seeing the first 3 cases of myelodysplastic syndrome emerge. Nevertheless, the FDA Advisory Committee unanimously approved Elly-cel, recognizing that the risk-benefit was in favor of this treatment given the progressive disease of cerebral ALD. And this became the first approved gene therapy for a leukodystrophy in the United States. So just to highlight here the process by which gene therapy is implemented and the timeline I want to point to, because timing is everything here. Once you mobilize cells, it then takes about 1 to 2 months for the manufacturing, where the cells are transfected with the lentiviral vector, myeloablation occurring, and drug product being infused, and another 2 months in the hospital after infusion. So these timelines are things that we are wrestling with as we are now in the commercial space. I'll just summarize that there's microglial cell loss in this disorder, that an open blood-brain barrier allowing for gene delivery through hematopoietic stem cells. More than 70 patients with childhood cerebral LD have been treated so far, both in the trials as well as in the commercial space. Most patients, 94%, achieve stable neurologic function without major functional disabilities. Safety events are related to mobilization apheresis, similar to bone marrow transplantation, but myelodysplastic syndrome associated with lentiviral vector related insertional oncogenesis is an important side effect that we are worried about and currently watching carefully. So just to highlight here, what is the insertional mutagenesis? Purpose of the vector is to insert into the chromosome. This occurs randomly, and we do not control where the vectors land. The ABCD1 gene is on the X chromosome highlighted here. So when we deliver the lentiviral vector, we are actually integrating into sites far beyond that of the X chromosome alone. You can have thousands of integration sites, and the ALD protein is made just from those sites. Insertional mutagenesis, just to describe what happens when a new gene is being inserted. You can see here on the left a wild type protein. If you have a new gene being inserted, this can now lead to a change in function of that protein. It can also change the amount of protein being made. Either you can have less protein or more protein made. So the inserted genes can impact the actions of those around them. This is particularly important if you're inserting into a site where there is an oncogene. So these are genes that promote or inhibit cancer risk. So oncogenes and tumor suppressor genes are critical in cancer development. If your delivery of the lentiviral gene it occurs into one of these oncogenes, there are different consequences that can occur. You can have either increased oncogene expression or decreased tumor suppressor gene expression. Either way, you now have a heightened susceptibility to malignancy. Just to highlight this briefly, what happens with the malignant clonal development after gene therapy. You see here the site where the delivery has occurred, and if that is an oncogene, that has a selective advantage in survival and can display clonal expansion that then over time leads to myelodysplastic syndrome or leukemic transformation. So cells carrying cancerous potential divide with risk of malignant progression. So this is, of course, what we fear most and we try to understand. And so far, what we've seen occurring is mostly myelodysplastic syndrome. This is an unhealthy bone marrow that now gives rise to more immature cells, decreased healthy blood cells. This will manifest with a decreased counts of platelets or decreased counts of red blood cells. And it has a high risk of transformation to what we call leukemia. This is what acute myeloid leukemia can look like on the right with blasts forming. So both of these disorders, myelodysplastic syndrome and acute myeloid leukemia, are clonal disorders where there's been expansion of clones, and cancers are forming. And why this is occurring in our ex vivo lentiviral gene therapy and why it's occurring so late is something that we're currently studying carefully. Here, the 5 boys that we know develop myelodysplastic syndrome. Unfortunately, there has been, as of last month, a 6th case of acute myeloid leukemia. And the boys so far known to us have gone through a bone marrow transplantation, and all but one of them went safely through this procedure. Fortunately, one boy died from graft versus host disease. But I want to highlight one thing, which is that the vast majority of these cases occurred with a chemotherapy regimen, fludarabine, which is a less toxic, less myeloablative regimen compared to the cyclophosphamide. And so in the commercial space, we're now only using cyclophosphamide, hoping that that is may be an important contributor to the prevention of MDS. So just to highlight that ex vivo gene therapy compared to allogeneic hematopoietic stem cell transplantation favored well over the untreated patients, clearly showing efficacy and benefit in survival. But we have to, despite the 91% of patients on 102 being free of major functional disabilities and surviving the occurrence of myelodysplastic syndrome is key and must give us reason to research further. So to conclude, newborn screening and community building has been integral to successful trial enrollment. I want to highlight what an important role Stefan Kemp's work and Elisa Seeger and Hugo Moser's contributions were to detection of boys early on. And without that, the trial would never have been successful as it was. More than 70% with early active childhood cerebral ALD treated with ex vivo lentiviral gene therapy to date. That in trials, most patients, 94%, achieve stable neurologic function without major functional disability. I will pause here and say that I'm very unhappy about the fact that in Europe, we cannot currently offer this to boys and families who have a childhood cerebral ALD, and particularly those boys who do not have a well-matched donor are suffering. So we need to change this and find new ways forward. The adverse event profile of bone marrow transplantation ex vivo gene therapy differs. On the one hand, bone marrow transplantation has engraftment problems and graft versus host disease. On the other hand, ex vivo gene therapy has these emergence of myelodysplastic syndrome I described, but both modalities have side effects of chemotherapy and immune suppression. So I'll just stop there to acknowledge all the people who contributed over the years. This really took a village, and many people contributing from all over the world. And I want to also have a big shout out to all the brave families who did so much to be a part of this trial and put their trust in us. So thank you, Stefan.
Thank you very much, Dr. Eichler or Florian, for this this wonderful overview and update on gene therapy, both the positive sides and also the unfortunate some negative sides. It's really impressive that this that this is ongoing, and I think again, as so often, ALD is a leading disease in moving forward, and it's I think it's very helpful that we have now multiple approaches and more to come. And well, that's a nice bridge to the next speaker. Dr. Elly Jasbeck from the Department of Pediatric Neurology.
Yes, you hear me?
Yes.
Okay, thank you. So, hello everyone. I am Elly Jasbeck. I am a pediatric neurologist in Paris, in the Center of Children Leukodystrophies. I work along with Dr. SEVIN and Professor Moschel, who works for adults mainly. So thank you, Ella, and thank you everyone for being here. I will talk to you about Nexus study update, which is an open-label phase 2 study on the safety and the efficacy of leriglitazone in the treatment of cerebral child ALD. So as you now know very well after these two presentations, ALD is an X-linked disease. It is the most common and frequent leukodystrophy. It is due to a variant in the ABCD1 gene, and it targets mainly the brain in males, but also spinal cord and peripheral nerves in male and females adult, and it also targets the adrenal cortex and the testes in males. So this variant in ABCD1 gene causes a toxic accumulation of the very long chain fatty acids, which is the biochemical disease marker that we find in 100% of men affected and about 75 to 80% of women affected. And as already explained, the genetic transmission could be from a mother carrier to her son or to her daughter, with a risk of 50% at each pregnancy. And when the father is affected, it is only to 100% of his girls, but none of his boys. So when the ABCD1 gene is mutated, the production or the function of the ALD protein, which is here, is deteriorated. So there's a default in the entry and the degradation of the VLCFA into the peroxisome. And when they accumulate, they are toxic to many cells, especially in the central and the peripheral nervous system, but also, as we said, in the adrenal glands and the testes. So in consequence, we have neuroinflammation causing the leukodystrophy because of the demyelination here. And in a second place, we have under the myelin sheath, the axonal degeneration and phenomena of oxidative stress and energy metabolism disturbance. I will first talk to you about the natural history of childhood cerebral ALD, so that later I can talk to you about Nexus and the leriglitazone. It would be easier to understand it this way. So the experience in France was based on the LeukoFrance registry of 52 patients identified with a CALD and a 10-year study period, among which 47 were more than 1 year followed up. The median age at diagnosis was 7 years. We had 62% of our patients who did not undergo the hematopoietic stem cell transplant, whereas 38% could have the transplant. And as you know now, because it was already explained, we use a neurological functional score to evaluate the symptoms. We call it the NFS score, among which we have the main major functional disabilities that cause the handicap into 5 points. What we noticed is that the children who had a CALD and did not undergo the transplant had many cognitive and motor symptoms. Whereas when they had the transplant, only one of them developed some cognitive symptoms, and they mainly had adrenal insufficiency with no neurological symptoms. As for the disabilities, when they had not the transplant, they had very common disabilities as loss of communication, use of wheelchair, incontinence, cortical blindness, tube feeding, or movement loss. But when they underwent the transplant, we had almost no disabilities except few cases of cortical blindness. And the key clinical conclusions of this was that an early diagnosis with only few clinical symptoms is always critical to implement transplant. So we should really consider the newborn screening and the family screening in France and in all the countries. Because the treatment with transplant or gene therapy has best outcomes when few symptoms or disabilities are present at the time of diagnosis, so that we can prevent the irreversible damage from the CALD. As for the clinical symptoms and the effect of transplant, this study presented the expected clinical deterioration in progressive CALD as a typical rapid decline from the first few months after diagnosis, especially from the 6 months after diagnosis. As you can see, the NFS score exponentially rises at this time. With HSCT, this neurological decline is halted or slowed down. So once again, early diagnosis and treatment are really paramount for a good clinical outcome. If we look to the imaging, which is the MRI, this study evaluated the lesion progression on the MRI scans of the pre-symptomatic CALD boys. There was a mixed retrospective and prospective cohort diagnosed at an early stage of the disease by the MRI scans. So the NFS score was 0, all pre-symptomatic boys at the diagnosis, and on the MRI we had still no evidence of inflammation, so no gadolinium enhancement. The results showed a median age at diagnosis of 6 years and a half, and by 6 months of the study, half of the patients become gadolinium positive with an inflammatory CALD form, and by 1 year and a half, 80% of them become inflammatory. Till now, the gold standard on the MRI imaging has always been the loss score, and it is very clinically useful. But however, when we repeat the scans on an early stage of the disease, this score may not be as sensitive when used alone. This is why, with the improving of technology, there's an opportunity now to use different methods to assess the early lesions in cerebral ALD, and especially methods to assess the volume of the lesions, so that we can understand the rate of the growth, and it helps us to understand the trajectory for the lesions and to identify the patients where rapid progression is occurring. As you can see here, the fold change in lesion volume across time is really exponential in the few first months. Now I can talk about leriglitazone and Nexus study in children, also called Minorix or MYN102. This medication is derived from a very old molecule called pioglitazone. It was used for diabetes, and now we use it in the leriglitazone form because compared to pioglitazone, leriglitazone has a good intracerebral penetration. It works on the PPR gamma agonist in the peroxisome, so it targets the very long chain fatty acids metabolism in the peroxisome, their beta oxidation, and it also has a real impact on the neuroinflammation and the oxidative stress locally. It is an oral treatment. It's a syrup that the boys take once a day after the breakfast, every day at the same dose. The dose is first calculated with a formula with the age and the weight, and then we adapt the dose with a pharmacokinetic study in the blood. It is a well-tolerated treatment in the boys, and we will see it again. And this treatment was first used in the disease in an international trial in adults in 2018 in AMN. It was the advanced trial. So Nexus is the study now in pediatric patients only with CALD. It's an open label design, and as I told you, it's now supported by a well-established natural history. The population targeted are boys aged from 2 to 12 years, and we have two groups. The group of non-enhancing MRI, so gadolinium negative, meaning they have a lesion that is not yet inflammatory, and the second group with gadolinium enhancing lesions, meaning that they have brain inflammatory lesions. The inclusion criteria is the same as transplant. So it's an MRI loss score less than 10 and a good clinical shape, so a neurological functional score less than 1. So pre-symptomatic boys mainly. The sample size, 23 patients were enrolled and 20 were evaluable. And we have two key points in this study. The first one, which we already now have the result, is the week 24, so 6 months. And the second key point is week 96, so 2 years, which is still ongoing. So I will mainly talk about the short-term assessment, where the primary endpoint is to have an arrested disease or a lesion growth deceleration without clinical progression. At week 96, we hope to confirm, of course, this primary endpoint of an arrested disease. There is also secondary endpoints, mainly on MRI, the loss score and the gadolinium enhancement, but also clinical scores, NFS and MFD, as we said, so neurological functional score and disability score, the survival. We also evaluated exploratory endpoints, mainly the volumetric of the lesions and some plasma biomarkers, but also perfusion on MRI. So this interim analysis showed positive results for now that at week 24 seem to be comparable to transplant and to gene therapy, indicating a real clinical and radiological benefit. On a clinical point of view, 95% of the patients at week 24 showed a disease arrest or a lesion deceleration on MRI. Of course, I'm always talking in comparison of natural history. 100% of patients showed no clinical progression and 40% showed an arrested disease. At week 96, which is ongoing, we will consider this study as successful if at least 5 over 20 patients meet this primary endpoint definition. At week 24, all patients remain clinically stable, and we can see here that the result on the NFS clinical score is comparable in liraglutide and bone marrow transplant, whereas it is much better than natural history. As for the cerebral lesions, they also stabilize at week 24 with a loss score profile here that is comparable to gene therapy and to HSCT. As for the volumetrics of the lesions, they also show a lesion stabilization because the lesion growth at week 24 was below the natural history for the majority of the patients. And if we take the plasma biomarkers, the results were also parallel to those from the volumetrics data, especially for the NFL marker. A key point in this study is that liraglutide could also be helpful as bridging therapy when we decide to go to bone marrow transplant. Because as you know, several patients enrolled were eligible for transplant, especially the gadolinium positive patients. So it would be very interesting to use liraglutide before, because lesion growth could stabilize while the donor search is ongoing. So that HSCT outcomes could be improved when the lesions are stabilized. And in this study, among the 20 patients, 8 at week 24 were undergoing an HSCT program. 5 of them had no significant lesion growth, and 1 of them was gadolinium negative. But as you know, the HSCT is still the gold standard treatment, so sometimes we decide to do it along with the doctors and the families, because some families do not want to take any risk. And 3 patients prior week 24 got out, so we had no time to assess the treatment effect on them. As for the safety, we noted in children that it's a real well-tolerated treatment. The main side effects clinically are the weight gain and the edema. But honestly, in children, we only see a little weight gain in the 3 first months, and then they tend to stabilize. So there's a lower incidence of weight gain and edema by comparison to adult patients. And as for the labs and the electrocardiogram, we had no safety flags or no significant findings. The boys are following their growth curves, and we had no discontinuations for any adverse event. So in summary, this study has enrolled 23 patients over 4 countries. The 6-month data is signaling a slowing down of the lesion growth, always in comparison to natural history. The boys are clinically stable at 6 months. The MRI loss score is similar to patients who have received transplant or gene therapy at 6 months. Leriglitazone is a well-tolerated syrup, and we are now awaiting to confirm this primary outcome at week 96, and the trial will be completed by the 2nd quarter of 2025. Thanks a lot for listening.
Well, thank you very much, Lise, for this very, very nice update on the Nexus study. This looks all very, very promising. And yeah, now we can only hope that week 96 will show the same results, because this looks very encouraging.
Yes, especially that we don't have anymore the possibility to do gene therapy now in Europe, so it is useful, yes. Absolutely.
We will move to the next speaker, because we will have a Q&A session at the end of all the presentations. And with that, I would like to introduce Lisa Schaefer from the Department of Neurology of the Leukodystrophy Outpatient Clinic in Leipzig University Medical Center. And Lisa will provide us with an update on the multi-professional online care for symptomatic women with ALD and the results of the SMART ALD study. And I see you're already sharing your slides, so that's really great. Then I will stop talking and I will give the floor to you.
Thank you very much, Stefan. So you can see my slides, I hope.
Yes.
Okay, very good. I would also like to welcome you from Leipzig, Germany, and I'm delighted to present to you today our SMART ALD study and the first results of the study. In this study, we investigated the effects of a new multi-professional online support program on the quality of life of symptomatic women with ALD. First of all, I would like to say a few words about the symptomatic courses in women compared to men, but we've heard it before. So as you know, the most common form of ALD in adulthood is adrenomyeloneuropathy, or short AMN, which typically leads to progressive balance and gait disorders, paraspasticity, and bladder and bowel dysfunction. And women can also develop symptoms of AMN, usually with a later onset from the age of 40 compared to men, where AMN begins in young adulthood from the age of 20 years. So clinical studies have shown so far that up to 80% of women over 40 years report symptoms of AMN. However, the frequency of symptomatic courses is probably overestimated by us, as we don't know how many women are pure gene carriers and do not know that they have ALD, as they remain asymptomatic for their entire lives, and they are, of course, not recorded in our studies. And in contrast to men, the development of adrenal insufficiency, or so-called Addison's disease, and the transition to cerebral ALD, in which inflammatory processes occur in the brain, is very rare in women with ALD, with less than 1% reported. Nevertheless, symptomatic women have often been neglected in treatment and especially in research, as their milder, slowly progressing course makes them unsuitable participants for clinical studies, testing, for instance, the efficacy of a new medication on AMN. For this reason, we started a study in Leipzig in Germany in 2022, in which we wanted to improve the treatment and the quality of life of symptomatic women with ALD using a multi-professional approach. The SMART ALD study was funded by ELA International and conducted under the direction of Dr. Wolfgang Köhler at the Leukodystrophy Center in Leipzig. And the aim of this lifestyle intervention, called SMART ALD, was not only to improve the symptoms of women through closer medical care from experts at our Leukodystrophy Center, but also to provide non-medical support to improve the mental health, the social medical care, and the self-efficacy of symptomatic women. For this reason, SMART ALD study included different multi-professional consultation modules, and participants could choose which and how many modules they took part in. In addition to neurological consultations, participants were also offered psychological, nutritional, social medical consultation, as well as an individual fitness training. And this allowed us to tailor participation in the lifestyle intervention to the individual wishes and needs of each participant. And an individual treatment plan was created together with the participant at the beginning of the SMART ALD lifestyle intervention. Further, all appointments during this study took place online via video sessions. It was therefore possible to take part in the entire study from home, and patients did not have to come to our study center at any time. So here you can see a map of Germany, and Leipzig is situated at the eastern part of Germany. So this online intervention allowed regular support and participation, even for women who lived far away from our specialized center in Leipzig. Unfortunately, all sessions of our study were in German, so we could only include German-speaking women, but at least we were able to include some participants from Austria and from Switzerland. In the following, I would like to go into more detail about the content of the individual consultation models we offered. Each participant received at least 3 neurological consultations, during which the current symptoms and their current treatment were recorded of each patient. If necessary, treatment recommendations were made by a neurologist experienced in the field of XALD. And these recommendations were also addressed to the patient's local doctors in order to implement them. And after 6 and 12 months, our neurologists at our center reviewed the implementation of our recommendations. And in addition, patients and their local healthcare providers had the opportunity to contact the study team directly at any time with questions about the treatment of ALD. Further, patients had the opportunity to take advantage of individual psychological consultation sessions, and these could deal with specific topics, for instance, coping with the illness or grief or stress management. But psychological sessions could also be used by patients as a protected space for emotional relief or reflection without there being a specific topic or concern. And some participants also simply wanted an appointment to clarify questions about the process and how to find psychotherapy in the local area if they wanted it. As part of the nutritional consultations, disease-specific dietary recommendations were made to reduce the consumption of the food rich in very long-chain fatty acids, and the individual consultations were based on the evaluation of a food diary kept by the patient over several days. And also participants received regular recipe suggestions by email during the entire period of study participation. If desired, patients could also take advantage of social medical consultations. In this case, a social worker assessed the participants' current social medical care situation in various areas. For instance, whether the care level and the degree of disability are correctly classified and the associated support in form of state aids, for instance, is being used. And in the event of gaps in care, the patient was informed about state aid and, if necessary, actively supported in making an application. So it has to be said that the social system in Germany is very complicated and bureaucratic. In addition, there are federal states in Germany, and in each state there are different procedures and applications for disability benefits. So as a result, many participants took advantage of the social consultations we offered in the study, and many participants were also underserved in terms of social medical care in the beginning of the study. And last but not least, the patients were also offered weekly fitness training sessions in an individual or group setting. The exercises were aimed at improving the patient's coordination, strength, and balance, as well as increasing their motivation to exercise and their self-efficacy. The intensity of the exercises was individually adapted to the patient's fitness level and increased as the training progressed. And in addition, the exercises were made available to the patients as YouTube videos to provide them with long-term guidance on disease-specific exercises that they can integrate into their everyday lives after study end. Oh, sorry. There are some slides missing. Sorry, I just have to check. No, here. Yeah, sorry. I think, yeah. So, this slide shows a graphic illustration of the study procedure SMART AED. In our study, we were able to include a total of 68 symptomatic women with AED. And to test the effect of this new lifestyle intervention, we randomly divided all participants into 2 equal groups at the beginning of the study, an experimental group and a control group. Participants in the experimental group were allowed to participate in the SMART AED multi-professional program for 12 months, and the control group had to wait 6 months before they could also receive and participate in the SMART AED intervention for another 6 months. This two-group design was necessary to investigate whether the self-reported quality of life and well-being after 6 months in the experimental group with 6 months of participation in SMART AED differed from the control group, which up to this point here, T1, had only received usual care without the additional online program so far. In order to record the changes in quality of life and well-being in both groups, all participants underwent a medical video consultation at the start of the study, after 6 months, and after 12 months. And this medical video call included a neurological evaluation. And further, all participants, independent of group membership, were asked to complete self-report questionnaires on the quality of life and health on the web platform LeuConnect, which is operated by ELA. And further, in addition, all participants were given a fitness tracker at the start of the study, which they had to wear continuously for 4 weeks at each of the 3 assessment points. So this allowed us to record changes in physical activity over time in both groups. Let's get to the results. I'm still analyzing them, but I would like to briefly present you the main outcomes to you today. In this table, you can see how many participants in the experimental group took part in the individual Smart ALD modules and how many in the control group after the 6-month waiting period. And the last column on the right, you can see the number and percentage of all participants in the experimental and control group combined for each module. And approximately approximately one third in both groups took part in the nutritional consultations, and they also used the offer for social consultations. And over half also decided to take part in the fitness training. And almost half took also advantage of at least one psychological consultation session, whereby the proportion of the control group after 6-month waiting period was a little bit higher than in the experimental group. And in addition, most participants of the experimental group took part in 3 intervention modules combined, while most of the waiting list control group even took advantage of all non-medical multi-professional modules we offered at the same time. Our main aim of the study was to improve the self-reported quality of life through Smart ALD participation. And we measured this with a questionnaire that assesses quality of life in various areas. And these values of the questionnaire are summarized in this table. Here you can see the results of the experimental group at T0, that is before the intervention, and at T1, which is after receiving 6 months of Smart ALD intervention. And here again for the control group before and after the waiting period without additional intervention in between. And after 6 months of Smart ALD intervention, the participants of the experimental group reported a greater vitality and mental health than before Smart ALD. You can see that the values are rising from T0 to T1 in these domains, while the control group showed unchanged values over time. And this effect of group and time was statistically significant. Further, the EEG also showed an improvement in other areas of quality of life. So also in other areas, the values are rising over time after 6 months receiving Smart ALD. But this was statistically not significant compared to the control group. We also analyzed other areas of well-being and health based on questionnaires and fitness tracker data. And this showed that after 6 months of SMART ALD, the experimental group reported an increase in knowledge of disease-specific nutrition and also of social medical benefits for disability they can apply for. And further, the fitness tracker data showed a significant increase in daily intensive physical activity in the experimental group compared to the control group after 6 months receiving this extra intervention. And also depression and self-efficacy improved. As you can see here, the depression scores went down and self-efficacy or more self-efficacy was reported after this intervention. However, this effect was seen in both groups. So also the control group showed a decrease of depression and an increase of self-efficacy, for instance. This could perhaps be attributed to the fact that the control group also had the outlook of an additional offer after the waiting period, which might already had a positive effect on the well-being of the control group. And in addition, some women of the control group came to our leukodystrophy clinic in Leipzig for the first time during the waiting period, as they had become aware of our specialized center in Leipzig through this study, and so they make their first checkup or their first visit appointment in Leipzig in a specialized center. I come to the end. In summary, I think our results show that easily accessible, multi-professional, disease-specific lifestyle interventions have the potential to improve the quality of life of symptomatic women with ALD, even after only receiving 6 months this additional program to standard treatment. And such additional online offers can also generally intensify the care of people with rare diseases who live far away from a specialized center. So we are currently examining the data in detail and investigating the long-term effects after 1 year in which patients benefit better from such an online intervention. We will publish the results, I hope, in the next weeks, and of course pass on our findings to you via the ELA communication channels. So I think my slide is somewhere else now, my thank you slide. I would like to thank you for your attention first, and I would also especially like to thank all the participants who took part in our studies, and especially also to ELA International who financed the study. And without them, our research wouldn't be possible. Thank you very much.
Thank you very much, Lisa, for this very important study for the help with women. And I'm really impressed by the fact that you do this online, so everybody can participate. And I think it would be really nice to have this in translate this to different languages. But of course, other centers will pick it up, but maybe they can benefit from your experience.
Yeah, that's the idea.
Yeah. Then I want to introduce the next, and if I'm correct, the final speaker of this session, Professor Fanny Michel, the director and coordinator of the Reference Center for Neurometabolic Diseases in, now my French, La Piété-Salpêtrière. Dr. Michel, Fanny will give an update on the French adult patients regarding new treatments and new monitoring. I'll leave the floor to you. If you can share your slides, Fanny, then I can check and then I'll stop talking afterwards.
Thank you very much, Stefan. It's a pleasure to be here today. Thank you for the kind introduction. Thank you, Ella, for the invitation. So indeed, I'm going to give you a little update on what we do in our reference center for adult leukodystrophy in Paris. with a major actually orientation towards the research and the clinical care for XALD in particular. I know that some of you connected were very well taken care of by Patrick Aubourg, and actually when he retired, I progressively took over his clinics, and we tried to organize that at the national level so that most actually adult patients can have some referrals. So if and I just also shared that in the chat, but if there are some families that have not been seen in a while, I think that now we can propose something that has been going on for some years already, that will hopefully help you and where you can find some answers. So I will briefly address that as well. I would start with my disclosures of consultancy and research grants. And I guess what would be one of the key message to start with today, because we are mostly going to talk about men with adrenoleukodystrophy and cerebral adrenoleukodystrophy, is a situation that we still see too often. When I took over after Patrick's clinic, we had actually many of these very sad stories. It's still something happening, not necessarily because patients are no longer taken care of, but because even if they have regular follow-up by neurologists, the community that is not familiar with rare disease in adult medicine still do not recognize enough what's maybe going on. So I like to illustrate that with this simple images and stories of a patient that we ended up meeting in 2020. But this are just some pictures of his brain MRI that he was not doing at a yearly basis. As Stefan mentioned, we recommend a yearly MRI, brain MRI. This patient also had myelopathy, but what was noticeable is mostly what happened on the psychological, professional domain of his life, with some sudden care change, followed by a depression that was thought to be related to this professional problems. And this is when I meet this patient in 2020, with then a rapid motor and cognitive decline, and unfortunately passed away just 2 months after this MRI, before the age of 40. And these are the mild but still very important abnormal signal of the white matter that should be detected. Florian has explained that in children, most of the cerebral form develop in the splenium of the corpus callosum. In adults, it's different. We have a lot of different forms. And this aspect can be under-recognized, especially because in patients with myelopathy, you may have some mild white matter abnormality here. And it's only when it becomes more inflammatory, also I'm not showing here, with some gadolinium enhancement, that this is very problematic, because this is a very rapid progressive disease then, and also unfortunately most of the time not eligible to transplant. So you heard already a lot about the disease. I'm just going to briefly outline again some of the key messages, that we are talking about the accumulation of the very long chain fatty acids because of the defective import into the peroxisome, because this transporter doesn't work properly. I'm only again talking in adult men for the sake of time, but we have about 80% of primary adrenal insufficiency, usually before the age of 40, in more or less all the men, but sometimes with age of onset way after 40. We have patients who start at 50, 60 years of age sometimes, but usually between 20 and 40 years. This spastic paraplegia was sometimes a peripheral neuropathy. And as we wanted really to point out today, and Elise has mentioned that in children, but those cerebral form of the disease that may start like here in the splenium, but again, a lot of different forms that we can see in adults. And we think that it's unfortunately probably more than half of the adults that will develop that. And there is no age where we should stop screening for this disease, because as just 2 weeks ago, we diagnosed a patient at 60 years of age who had no sign of myelopathy or adrenal insufficiency, and who just started with the cerebral form, again at 60 years of age, and is 6 months in the progression to dementia. So a very rapid course. So we have to think about this in adults constantly, because again of new treatments. The transplant has been already alluded quite a bit, so I'm not going to explain much more. But just to say that again, here we are focusing mostly on those immune cells that we call the macrophages, or in the brain, the microglia, and those cells originating from the bone marrow. So they are not cells originating from the brain, and that's why we can replace them with bone marrow transplant. What is interesting is that those cells, those immune cells that are in the brain, especially here for the microglia, together with the neurons and the oligodendrocyte who produce the myelin, they have those switches. They can be either pro-regenerative or pro-inflammatory. And of course, depending on what they need to do in the brain. And the switch between the two status actually is driven by some metabolic changes. And this is probably where ABCD1 intervenes, because ABCD1, and this is work in particular from the group of Johannesberger and Isabel Van Hofer, showing in the macrophages that indeed this mutation is going to have a kind of a block into these metabolic switches and leading the cells to be pro-inflammatory. So the transplant is very efficient when it's performed in the early stage. If it's the patient is young enough, because in adults we face the problem that after 50, 55 years of age, we can no longer perform transplant because of the high toxicity of what we call myeloablative procedures, where we have completely to replace the bone marrow. And some patients may not be eligible either because they don't have a donor, because they are too old, but also because of this internal capsule involvement. This is the MRI I showed you before. So this very small, with a very small low score, but still very dangerous lesion that progress very quickly. Here we can see that patients that were transplanted with these lesions actually all died from transplant. So there is definitely a need for else than those procedures, and either again because of the lack of donor or age or this kind of lesion. And this is where, as Elise mentioned, the development came from pioglitazone initially to leriglitazone. And if I bring this picture back here, it's just to show that the drug is precisely going to act both on this mitochondrial metabolic here target, having a positive energy effect, and also anti-inflammatory through this negative feedback on this NF-kappa B pathway. So it's having both this mitochondrial action and anti-inflammatory action. And again, the trick about this drug is the great in vivo brain penetration. So Elise mentioned this study in which actually she contributed largely when she was working at La Salpêtrière, that Minorex conducted in 160 patients in 10 centers. I'm just going to show you very briefly the summary results. So the primary outcome measure on which the study was powered, so on which the number of patients was determined, was actually negative. It was a 6-minute walk test. We had, though, very interesting secondary outcome measure. And we know, by the way, that even if the regulatory agencies really like those tests, they actually not very, they can lack sensitivity, but mostly specificity to what they measure. So we were actually very interested that the body sway, which is at the center of the myelopathy, actually showed significant improvement in the patients that were treated. This is data after 2 years comparing placebo and patients on treatment, but there is now, of course, data of the follow-up of that and confirming this improved gait control when patients are under treatment. Patients may not perceive it, and because of the edema, as Elise mentioned, that can relate to the drug, some of the patients stop taking the drug because of the lack of perception of benefit and possibly some of this weight gain and edema. But we are now very well aware, and that even if there may be an effect on the myelopathy, even if this is still a small effect, where we were very happily surprised was that it means that during the trial, the occurrence of cerebral lesions, the occurrence of cerebral ALD was significantly reduced in the patients that were treated. So it tend to say that leriglitazone could decrease the conversion to cerebral ALD, could protect, delay, we don't know yet, but definitely here had an impact on that aspect of the brain lesions, which again are the lesions from which patients die. So we asked her very quickly this question in France about whether or not lerilitazone could halt or slow the neuroinflammation in patients who have already developed cerebral ALD, in patients who have already symptomatic from the cerebral ALD. And of course, it's been particularly for those who were not eligible to transplant because of the lack of donor, because of their age, or because of threatening lesions, as the one I showed in the very beginning of the talk. So these were the patients that we treated under a compassionate program in France, either because, again, they were awaiting a donor, and in the wait for the donor, we started treatment, or because they were not candidate for the transplant. We did not treat patients that were too advanced in the disease because we thought that quite likely the drug would not be helpful there. This is the kind of measurements that we conducted. We did both some classical motor function assessment, neurocognitive battery, some, of course, assessment of the brain MRI with standard scores like the LOWS or the gadolinium, but also new tools that I'm going to present very briefly, and the NFL, which is an important biomarker of inflammation in the brain. I just want to emphasize that even if this was a compassionate use of the drug, we conducted that in the format of a clinical trial with a lot of standardization and rigorous assessment. And I want to thank in particular our neuroradiologists, Maya and Gold, for the volumetric analysis, because they're extremely time consuming, but very helpful to understand what's going on, as Elise mentioned. So briefly about this diffusion tensor imaging method, what is it? It's a way to analyze the white matter trophicity in the brain with different kind of parameters that are going to show more of some inflammation, of water content, of fiber density. The new thing about here is not this method, which is known for many, many, many years, is this idea of this biotech BrainTel to basically define a pipeline that calibrates, standardize, and quality control these parameters. So in the end, you have a map of DTI, which is like a brain MRI for one single individual that you can see and follow over time. So the analyses are performed in 19 regions, and I'm going to show you what it looks like. So for example, for patients with bone marrow transplant, like this patient here who was 21 years of age, when he developed this small lesion here of cerebral ALD without any sign clinically, he was transplanted, and this is images at 3, 6, and 12 months. So you can see that the transplant was very efficient, stopped completely this demyelination. Now he's 4 years after transplant and doing very well. But what you can see with the DTI is that you see all the alterations that you cannot see just with your eyes, and that you can follow on an individual basis, which is very useful because it doesn't need to be in a clinical trial or a research trial. You can just do that, at least for France, in clinical routine. And you see at 3 months, there are a lot of changes because of the bone marrow in the brain. And then with time, it improves. And at 1 year, it's even better than what we had before transplant. So what does the lerilitazone does on the clinical parameters? So this is showing data in 13 patients that we treated and for which we have data for a year or 2 years. And you can see that most patients remain completely clinically stable, except for actually 2 patients, the ones that are here, who were patients with more of cognitive alterations and also older. They were after 60 years of age when we started treatment. This is the AACS score that was developed by Wolvenkoller in Leipzig, where we see the same thing of stabilization in all patients except for those. About the changes in the low scores, so quantifying the cerebral lesion, it's the same except for the patients who did not respond. And in the end, we had 3 out of 10, out of 13, sorry, who did not. For all the rest, everything is extremely stable. For the NFL, we did not have measurements in all the patients, but this is one patient who did not respond. This one patient is interesting because he showed something that was worrisome, but finally was able to normalize his NFL levels, and he's very stable clinically speaking, but he did have some worsening, we think related in part also to alcohol, which was aggravating his symptoms in the cerebellum in particular, which then improved when he stopped alcohol. The last part is one of the work of Marianne Gols, who shows precisely the lesion changes and quantification of the lesion volume. You can see the stabilization in all patients except for those two. Again, also, I mean, including the one patient I mentioned with alcohol consumption. But what is very interesting for us, because this increase was related to the cerebellum only, so this posterior part of the brain. But what was very interesting and important is that the cortical spinal tract, so basically those lesions from which patients die very quickly, like the first patient I mentioned, these ones were actually stabilized or even decreased under treatment. So the reason why those patients could not be transplanted actually and led them to be treated by leriglitazone, we could show that the drug is particularly efficacious on these aspects of brain lesions, which is of course very important. So I'm showing you a little bit what it looks like. Those severe lesions that we know are again usually evolving into death within 2 to 3 years. At baseline with this white matter enhancement and gadolinium enhancement. And you see over time how that has improved over 1 year of treatment with disappearance of contrast, like you would see basically on transplant. And the same for those lesions that were the same as the one I showed you earlier on, with also a decrease and then disappearance of enhancement and stabilization and even reduction of the brain lesion on this cortical spinal tract. So where are we today also for the DTI? This is a patient who responded very well to treatment. As you can see, his maps have really fully stabilized. And instead, this is one of the two patients over 60 years of age with cognitive alterations already important when we start to treat them. And you can only see very well the progression of their lesion. So today, where are we with this drug in adults for France? Well, we have 10 out of 13 patients followed after 1 to 2 years, for which the disease has stabilized both clinically and radiologically, and for some of them, again, with also even improvement of the brain MRI. Out of the 3 patients, 1 died after 3 months only of COVID. So it's impossible to say what the drug could do because it takes at least 3 to 6 months to see an effect. And for the 2 others I mentioned about their evolution. The 5 patients who were on a transplant list actually at the moment do no longer require transplant. The factor of poor prognosis were patients with already marked alteration in cognition, so the same poor prognosis than for transplant. But again, the difference with transplant here is that we can possibly treat patients with those cortical spinal tract lesions. And since those 13 patients, we have treated 5 new more, for which we have for 3 of them, an evolution already of 6 months. And we see exactly the same thing on these 3 patients with disappearance of contrast after 3 months and lesion stabilization over 6 months. So this is definitely changing a bit of practice today in France for adult patients with cerebral ALD, because we do use leriglitazone as a first-line treatment for the moment. And of course, while preparing transplant for the ones who are eligible in case they do not respond to leriglitazone. But it means that in the past 2 years, we have not conducted transplant for adult patients with cerebral ALD, whereas we definitely did in the years before. So I would like to finish with 2 slides to tell you a little bit about our other research activities that we conduct in the center. So this marker that I showed you with DTI, we think that it can be predictive of the conversion to cerebral ALD. And this is data that we gathered in the advanced study where we could show that the patient who converted, the ones who were on placebo, actually had a change in one of the DTI index a year before what we can see usually on brain MRI. So we want to validate that through a multi-center French study involving 12 centers. And this is funded by the Ministry of Health in France and will start this year in 100 patients that will be followed for 3 years. The other thing that we want to do is to, like the work conducted in Vienna by Johannes and Isabel, is to work on how we can better understand the disease from studies in macrophages. And for that, it's work that we are doing with my colleague Violeta Zejovic, who is a researcher in neuroimmunology at the Paris Brain Institute and also funded by the Ministry of Research. And we are also conducting this study in women, adult women with myelopathy, to actually better assess disease progression, also including DTI markers, and this study is funded by Minoix. For the clinical activities we are also doing in the center, for which you should be aware of, we have developed this PNDS together with Caroline SEVIN for the children, which is something very important for general practitioner, for neurologists to be aware of the disease and how the patient should be followed and when to contact us. We have this program of a therapeutic education for patients that we also developed with Caroline called the Locodyssée that we started last year, both in men and women, and it's also for children and adults. And lastly, we have a website in construction for which I'm showing you the new logo that will help you to navigate and contact us and be aware of the different activities we are conducting. So I'd like to thank all the team here of course, doctors, but also clinical research assistants, neuropsychologists, dietitian, the group of Vienna, Isabel and Johannes, who've been collaborating with the biomarkers for the study on eriglitazone, Minoix and Brentel. And please do not hesitate to contact us at the Leukodystrophy Adults Center in Paris. This is our team, and we'll be very happy to try to present to you the new opportunities that we have for clinical care and research in adults with ALD. Thank you.
Thank you very much, Fanny, for this really, really nice overview of what's going on now in France. And it's really exciting to see that you're rapidly expanding research line, treatments, care of patients. And yeah, this is really, really nice to see. Thank you very much for that.
And so, first of all, I would like to apologize because I have this is like a kind of general presentation that most of the time I use in French. So the slide are in French, but I will speak in English, of course. So I just want to give you some key, let's say, numbers. As you know, there's like 6,000 to 8,000 genetic rare diseases that are actually described. And in France, it corresponds to 3 million of people concerned per year. And around 30 million in whole Europe. If we consider all the rare disease together, it's around 1% out of 20 that are concerned by a rare disease. And most importantly, it concerns young people because 50% of the person with this kind of disease are under 18 years. To start with, all we can discuss about DNA. We have all to know that I will put a pointer that will be easier, that our organism is capable of those things, jumping, running, breathing, walking, and all these can be done just because we have specialized organs all over the bodies. These organs can achieve their function due to a tissue which is formed by several cells. And into the cells, you need to have in mind that in a human body, there's around 10,000 billions of cells within the whole body. And in all of your cells, there's what we call the nucleus. And within this nucleus, there's the DNA. This is like, you know, when I speak also to children, I like to say that it's like a book. The DNA is like the book. Within the book, you have some chapters that are done by the chromosomes. Within the chapters, you have sentences, and in genetic, this is the gene, and the sentences are formed by words that correspond to the codon in the genome. And the words are formed by letters. We have a complex number of letters in the French and all the language. And in the DNA, it's much more simple because you have only 4 letters, the C, the G, the A, and the T. And they are all assembled by pair. The C can only assemble with the G, and the A can only assemble with the T. And here is a kind of example of the 3D structure of the DNA molecules that has been discovered by Watson Crick and Rosalind Franklin years ago. The DNA, how does it work?
So as I just said, you have DNA in all of your cells. And if you would put along, like, you know, a string, the DNA that we have in all your cells, in each of the cells, you have 2 meters of DNA, which means that if you put close one to the other, all the DNA that we have in the cell of our body, you can do 3,000 times the go and back distance between the Earth and the moon, sorry. But for this, we need to have like a data sheet of all these works. And here you can see, oh, I like to exemplify this like for children. It's like if you get a Lego box at Christmas. If you have all these without the notice, you would never be able to build what you aim to. And this is the same thing for the genome. All the information that is contained in your chromosome will allow you to have an organism built with all the molecules that are made of. But where is our DNA coming from? It comes from the father with the spermatozoid and the mother with the ovules. And when a fetus is formed, you have just a mix of the father and mother DNA. And this is a unique mix that will compose the new organism that will then develop. And to try to give an example of how this works is like a unique identity card. The first things you can know is like whether you will have a girl or a boy. Within the chromosomes that we have in our genome, we have what we call the sexual chromosomes. If you are girls, you will have 2 X chromosomes. If you are a boy, you have an X and a Y chromosomes. It means that the mom can transmit within one or the other copy only X chromosome. The father can transmit with a spermatozoid either the X or the Y, which means that for a couple, you have 2 possible combinations, either the boy with XY and XX. But this is for all the characteristics that we have in the organisms. And here, for example, for the color of the eyes, you have the B for the brown and the small b for the blue. And here you see the difference between the capital letter and the small letter. This is because you have one allele that can be dominant on the other, which means that if you have 2 copies, one of the small b for the blue and the capital B for the brown will dominate the blue, and the mother, or here the father too, will have brown eyes. But you will see that in the baby, you have indeed 4 possibilities, because the mom can transmit either the blue or the brown, and the same for the father, which means that in the newly formed fetuses, you can have 4 different combinations. The 2 capital B, so that will give brown eyes, the capital B from the mother and the small b from the father, it will give again brown eyes, the small b from the mother and the capital B from the fathers, and it will give brown eyes too, or the small b from the fathers and the small b from the mothers. And in this case, you will have a baby that got blue eyes. And this would be the same for all the characteristics you have in the body. So the eyes, the sex, the color of the hair, and then for all your proteins, all the proteins that are encoded by your gene, you have 2, let's say, copies of these, one from the mother, one from the father. And how can we come from the genome to the protein? So in the genome, I just told you that you have the chromosomes until the DNA with this compound with AT or CG and all the list. As I told you, this is like a copy that we should not affect within the body because it's crucial to keep it intact. And so the organism in all the cells is making like a copy, which is what we call the RNA. And in this case, you see that it's exactly the same translation with only one difference, which is the T for timing, which is replaced by a U within the RNA. And then you will have like translation of 3 letters by 3 letters to give the protein. And it's like, you know, pearl that will be assembled one to the other. These all are the amino acids to build a protein. And once you have the full protein form, it will give, it will adopt a 3D conformation. And this is something fundamental, because you will see after with the mutation that sometime one of the problem could just be that you change one single amino acids, and this could dramatically affect the protein because it will fully change the structure of the 3D, and thus the protein will be no more able to assume its function. And we are coming to what happens if the data sheet is not well translated. And this is the case of genetic disease. As I just said, there's not only in the chromosome, there is not only one copy, but two copies of the gene. And what happens if there's only one for the dominant disease, as we just heard about ALD for the people that were presented in the previous session, or for recessive pathologies, as we will discuss with Pelizaeus-Merzbacher, but also, as you know, with like metachromatic leukodystrophy or other. In the context of leukodystrophies, it touched the myelin. You all know that you have the neurons with the long axons and the myelin which inform along the axons that make like an isolation to this axon and allow the proper transmission of the information. And this is what it looks like when we are doing small cut of the myelin and looking this using an electron microscopes. You see here, this corresponds to the axon. This is the myelin sheet with his well wrapped. When we have a diseased pathology like a leukodystrophy, you see here what happens. You have progressive disruption of all the myelin sheets that will then lead to problem of propagation of the messages. And when we come back to this ultrastructure of the nerve, you can see that we have a dramatic change between the normal and the diseased one, with axons that are getting degenerated and the myelin, which is normal form and which is decompacting and fully abnormal. So how can we identify a mutation? The first step is that we need to extract DNA, and probably in the family, most of you have been submitted to that, is like collection of blood. Then we extract the DNA. We will purify the DNA to be able to remove all the impurity that will be inside. Then we will cut the DNA in small fragments and prepare what we call a DNA bank. Then we can sequence this bank of DNA to have all the reads. You see here the A, C, G, T, C, G, T. And then we can analyze the sequence of DNA and we can compare to the normal genome without mutation. And by this way, we can identify either single point mutation or deletion or insertion that could cause the pathology. And here is like an example of what happens. Here, this is the normal protein as we speak before with different amino acid, methane, lysine, phenyl, and glycine, and there's a stop codon. Once we have this proper read, then there will be the 3D confirmation, as I said before. In the case here, if you see, there is a missing codon with the AAG. What will change? The first one will be the methionine is normal. But you see that after you have, let's say, a shift of the structure with directly the phenyl, the glycine, and the stop. So in this case, you will just have a shorter protein. We will see after whether it can impact or no the role of the protein. In the case of an insertion, you see here that we just have an insertion of a U close to the AUG. And you see that in this case, it's fully dramatic because just after the methionine, there's directly a stop codon, which means that we have no more production of the protein because we just have one amino acid. And in this case, we can already say that there will be dramatic effect and absence of the protein. If we now have a U which is missing a bit further, you see that in this case, the methionine will still be here, the lysine will still be here, but then you will have what we call a shift of the radic frame, and it will change a bit the structure of the protein. Instead of phenyl, you will have a leucine. Instead of a glycine, you will have an alanine. And this, we will discuss after, depends on the condition, either didn't change so much and will just give a protein that will have similar composition, and just maybe shift a bit the structure, but will still be able to achieve its normal function. Or sometimes it can completely change the structure of the protein just because due to the shift of amino acid, it would change the 3D structure dramatically. And then you will have, instead of having a protein like that, you can have a shift. And in this case, if it's like an enzyme, it can completely change the fixation of the substrate and avoid the degradation of the substrate. And we can come back to that after. And so let's take the example and the, let's say, images of a plane. If a plane has been, let's say, constructed in a wrong way, what does it mean? Like if you forget to put the, I have a mess of the word in the translator could say the L, the plane will not be able to fly. That's for sure. You can have a plane which is fully similar to the normal plane, in which we know that something is missing, but we don't know what. But it will work normally. You can have also a plane with just one seat missing. In this case, there's no problem. It will be fully functionable and usable. You just have one passenger that will be not able to be in. And this can be just, if we come back, this kind of things. You just miss a plane, but will not change the function. If on the contrary, you have a plane normal from the exterior port, but inside you have no seat, it means that the plane is able to fly. But if the aim is to transport passenger, you will never be able to put any passenger in. And this can be similar like to that. For example, it just changed a bit, but leads to a stop. And in this case, okay, you have the plane, but you cannot achieve of transporting passenger. And this is exactly the same thing that can occur within the body. You can have dramatic changing with no protein and dramatic cause. No change, similar function, and it kind of works more or less, or something that, let's say, from exterior is normal, but will not like, I could take the example here of methachromatic leukodystrophy. You have the ORSA protein, but it's not able to catabolize the sulfuride. Here, you cannot transport passenger, and so you will develop a disease. And why in the lab? Because I just explained how we can identify a gene, and this is especially important for the patient who suffered from undetermined leukodystrophy and wants to know how we can understand which kind of disease they have. And the next step, once we identify a new gene, we want to understand what's the function of this gene. And one of the best way to do that in the lab is to remove the gene into a mouse model and to see what it leads to. In some time, and we already identified that for the disease, it gives embryonic lethality, which is the case of around 30% of the whole gene that we have in the body, is that if you lack the protein, it will be lethal at the embryonic time. And this can be linked sometime in some family to people who try to have babies and are losing the babies around 4 to 6 years of this gestation, whereas the gestation was fully normal, and it happens that at a point they lose the baby. Sometimes can be linked to a dramatic loss of a protein. You can have sometimes a mouse that is without any visible differences. It could be because you have another gene, which is within the body, that could help to the function of the missing gene. You can have a mouse which is fully viable and functionable just because this gene is not, let's say, crucial in terms of viability and functionality within the body. You can have also a mouse which is fully viable but not functional. And this is the case of genetic disease. You can have a mouse which is viable but could have difficulty to walk just because, as we said before, there is a mutation within the neurons and thus it will not be able to walk properly. And you can tell me why we are looking to the mouse to have a kind of mimicking what occurs in human. And I think it's nice to make the analogy for the plane that I just used. You can use an Airbus to go to the US, but if you just want to evaluate the capacity of flying of a plane, you don't need to have a big Airbus. You just need a small plane. You will understand how it flies, the role of the motors, the role of everything to give all the response. And this is exactly the same of the mice. This is a really good model of the genetic of human. It's mimic what occurs. It does not copy, it just mimic what could occur in human. And it's exactly the same. So they are not copying the human disease, but they are mimicking the human disease. And that's how we can have a mouse model. We can recapitulate the features that occurs into the patients so that we can understand better the pathophysiology of the disease, and then we can imagine to develop a treatment. And what are the kind of treatment that we can develop? I would say that there are three major types of treatment that can be developed for all disease and especially for leukodystrophy. The first one is what we call pharmacologic treatments. It's the use of chemic molecule that could either help to alleviate the dolors or to try to fix dysfunctioning in the cells. If some of you were present before to the presentation that we had in the ALD session, this is the kind of treatment for the mean 102 that Fanny just presented in the case of the ALD. We can have also cellular therapy, which in this case would aim at having normal cells from either another organ within the body or from a donor that could replace the diseased cells. And in this case, we can notably use the stem cells. This is what has been done in the metachromatic leukodystrophy with the ex vivo gene therapy, and it's a mix of cell therapy and genetic therapy. It has been done also quite widely in adrenal leukodystrophy with the bone marrow transplantation. And more recently, since maybe now 15 to 20 years, the gene therapy has been developed, which is a kind of surgery of the gene. It aims at inserting or repairing a gene to allow the production of the normal protein within the diseased cells. And how does this work? For that, we need to bring what we call a drug gene. And the main question of the researcher is how to efficiently bring this gene to all the cells of the organisms. Because if you think about leukodystrophy, most of the time you have disease within the brain, but also within the spinal cord, within all the peripheral nerves. And when we aim at bringing this drug gene, we need to be sure that we will bring it efficiently through the whole cells of the body. And for that, finally, one of the best, let's say, vector that we found easily to deliver and efficiently to reach large number of cells, they are the virus. But we need to come back on how do a virus work, because I think you're all familiar with virus. One of the most, I think, known virus we have now is the COVID virus after the pandemic. And with a normal virus, what happens? If a cells get affected by the virus, the cells will start to produce the virus, and at a point, the cells will be so charged of all the virant that it will explode to liberate all the variants. This is how a virus multiplies. But this is dramatic for the cells, because as the cells will explode to liberate all the virus, the cell will die. And this is not what we want in terms of development of a therapy. So what has been done in the lab to use in gene therapy is that the virus has been modified to keep only what we call the capsid, which is the envelope surrounding the vector. And within the virus, we remove all the gene encoding for the virus. And instead of that, we put the gene, the transgene that we want to overexpress, so the protein that miss, the gene that encode the protein that miss into the disease. So for that, when we will call it vector for the gene therapy, will infect the cells. It will deliver the drug gene that will then be able to be expressed by the cells and will allow to shift from a diseased cells to a cured cells. And for sure, this step is quite long, because you need to imagine that when we start from undetermined leukodystrophy, we need first to identify the gene which is responsible of the disease, and then to be able to understand the pathophysiology, and most of the time by, let's say, building a new mouse model or a new animal model of the pathology. Then we need to think about the therapy and to test, as we call, as a preclinical work, and be sure that in the new model that has been developed, we can have a therapeutic benefits by developing the therapy we want to. Let's take the example of a gene therapy. Once all the steps have been passed within the mouse model of the disease, we will need to shift to large animal model of the either of the pathology or naive, let's say, animals, just to evaluate that the new treatment we develop is not toxic to the body. And once we have proved in the animal model that is efficient, and then in the large animal that there's no toxicity associated to, we can submit a request to the ANSM or EMA or FDA, whether it's in US, to get a phase 1 and most of the time a phase 1/2 trial that will aim at evaluating human the therapeutic efficacy, but also the tolerance. Once we reach the clinical outpoint in this phase 1/2, we can have a phase 3 on larger number of patients to really evaluate the efficacy. And then we can shift to a phase 4, where there will be a large number of patients treated. And at the end, we can aim at obtaining a FDA or ANSM approved drug that will be used to the whole number of patients that we have. So it's kind of a long journey, but there's a lot of things that are now ongoing on the treatment of leukodystrophy in the lab, especially. And I'm sorry for that, because I was not able to develop more. We have actually 2 therapeutic approach which are ongoing on the Pelizaeus-Merzbacher disease. But we just demonstrated that are efficient, and they are under patenting, and so they are confidential right now. But I hope that next year I would be able to share the nice result we are getting with this approach. And with this, I will stop my presentation. And I think that, I don't know if, Nicole is connected. And the next speaker will be Nicole, speaking more on Pelizaeus-Merzbacher disease, now that you know everything on genetic.
Françoise, thank you. I will share my screen. Okay, you should see my slides now.
Yes.
So thank you very much for inviting me to speak this afternoon. I would like to talk about a little bit of news on Pelizaeus-Merzbacher disease, or PMD. My disclosures: I'm a PI for 2 studies sponsored by UNIS concerning Pelizaeus-Merzbacher disease, so I think you should know that. I'm from Amsterdam Leukodystrophy Center, and the head of that center is Marjo VAN DER KNAAP. And just to start, I would like to tell you what we are doing in Amsterdam. A lot of basic research into leukodystrophies, looking for the disease causes, the disease pathways for several leukodystrophies, and we do that in different disease models, mice, cell cultures, but also brain tissue donated by patients. We do a lot of MRI research and biomarker research in body fluids. We look to for clinical outcomes. We participate in clinical trials and have set our own clinical trials. And we also, because unfortunately, and I think you know that best, can't offer all patients causal treatments or participation in trials. We also provide symptomatic treatments like spasticity treatment with intrathecal baclofen, and also deep brain stimulation for selected patients. And that we are doing with the whole team in the hospital. You heard already a little bit on myelin. Myelin is the insulation material of nerve fibers, and myelination is the process of making myelin and wrapping nerve fibers. Hypomyelination is myelin deficit, and Pelletier-Schmerzbacher disease is a disease with a severe myelin deficit. It's needed for the fast, we call that also saltatory impulse conduction in nerve fibers. And that has for long been regarded as the main function of myelin. But it's also very important to protect axons and also to provide nourishment to the long, very thin and very fragile axons. So it's a very important part of the white matter, the myelin. The normal myelination actually takes place during the first 2 years of life, when the oligodendrocytes, that's the myelin-producing cells, proliferate, mature, and then produce sheath, which then wrap around those axons as it should be. And you can follow that very nicely on MRI. You see that MRI of a newborn baby, and after 2 years, it looks completely different. The white matter is now almost black. It was almost white in the newborn babies. In Schmerzbacher disease, this process of maturing and proliferation and maturation of oligodendrocytes does happen. So there is almost no myelin. And you see that also on the MRI. That's again a newborn baby, and that's the MRI of a 4-year-old child with Schmerzbacher. And you see that the white matter still looks almost white. So it hasn't myelinated much. You see here a little dot of myelinated white matter. So there is some myelination in Pelletier-Schmerzbacher disease, but not almost nothing. And that's the main problem in PMD. Pelletier-Schmerzbacher disease is caused by mutations in the gene PLP1. PLP1 stands for proteolipid protein 1, and that's the most abundant myelin protein. It's expressed in oligodendrocytes, and there are 2 different forms of the PLP1, a long form and a shorter form. The most frequent genetic change of PLP1 is a duplication of the entire gene. So you have on one X chromosome 2 copies of the PLP1 gene. As boys only have 1 X chromosome that doubles their gene dose. You can also have, and you heard that just in the talk of Dr. Piguet, you can also have missense mutation, changing only 1 amino acid. You can have mutations where the whole PLP1 gene disappears and you don't have PLP1 protein. You can also have not only a double copy of the PLP1 gene, but even 3 copies or even more. And you see that in that lady who has on 1 X chromosome 3 copies of her PLP1 gene. And you can also have mutations in the non-coding areas of the DNA, which give rise to a very specific subtype of Pelletier-Schmerzbacher disease. The clinical spectrum is very broad in PMD. Many of you will know that better than I do. You have the classical form, which is usually the form you find with duplications of the PLP1 gene. And that's patients were sometimes able to sit without support, sometimes able to walk with support. I know patients who are able to talk very well with the classical form of PMD. Also patients who are not able to speak. So even within the classical PMD, you have quite a spectrum. You have the very severe form we call conatal PMD, where you can have breathing problems from birth and where you don't reach motor milestones, but where you are able to have a good contact and understand a lot of what's going on. The very mild forms of PMD are the forms where you have only spasticity, even late onset spasticity, sometimes accompanied by some more symptoms like the eye wobbling, the nystagmus we know from the other PMD forms. And mild mutations cause mild forms, obviously severe mutations, the severe forms. What we know in Pelizaeus-Merzbacher disease is that the amount of myelin we see on the MRI correlates with clinical severity. So the patients with a severe presentation have much less myelin than the patients with a mild presentation. That gives us to think, of course. Some aim of the treatment of Pelizaeus-Merzbacher disease would be to increase myelination, to increase the amount of myelin in the brain. So myelin, the amount of myelin is a good biomarker for Pelizaeus-Merzbacher disease. What we see in patients later in life is that the brain tissue decreases, it shrinks a bit, we call that atrophy, and that's probably also a biomarker for Pelizaeus-Merzbacher disease, although it's much less studied than myelination alone. We also like to have biomarkers in body fluids, especially in blood or urine, because that's easy to get, but we don't have good biomarkers yet. One biomarker we tested in patients is called neurofilament light, which is a good biomarker for other leukodystrophies. It's a protein which comes from axons and it spills over in CSF and also in blood. So we can easily measure it in blood. And we see those are patients, and the blue dots are NFL, neurofilament light levels. And you see that it's it's a little bit increased compared to controls, but we have not enough experience to know what it means. So we need to really look into that deeper to see whether it helps, whether it's a useful biomarker or not. Regarding treatments, currently there's only symptomatic treatment. And the problems of developing causal treatment are, of course, it's an ultra-rare disease, so we don't have many patients, which makes it difficult to understand well the course without treatment, also because the clinical presentation can be so diverse. Mouse models are available for PMD, but we know from other leukodystrophies that not all data in mouse models are relevant or transferable to humans, and not all treatments that work in mice are also effective in humans. There is still a lack of natural history data, although there are a lot of initiatives to improve that situation. And those are needed to decide whether a treatment works or not, because you need a good comparison. There are different mechanisms of pathology, not only the lack of myelin, but also on the longer run in the disease, axonal problems are getting more and more important. So it's not only one factor we have to look at. And you can, of course, look for hypomyelinating disorders in general to individual treatment approaches per disease versus influencing global mechanisms like myelination, inflammation, or axonal health. And what's more important is also not known. I think from experiences with other leukodystrophies, the really disease-specific treatment approaches are the ones with most promise, because we try to treat inflammation in ALD or in metachromatic leukodystrophy, but it didn't really change the disease course. As additional treatment, in addition to causal treatments, it might be useful, but not as a significant only treatment. So that's also something we have to keep in mind. So what are possible treatment approaches for Pelletier-Merzbacher disease? We could look at alternative substrates for axonal nourishment, and that might be ketogenic diet. The treatment of inflammation, because inflammation has some role in PMD, but as I just said, from other leukodystrophies, we haven't seen so much effect of those approaches. There has been a treatment trial, and I think many of you are aware of that, where 4 boys were treated with transplantation into the brain with neuronal and oligodendrocyte precursor cells without side effects also. And there have been quite some approaches to use cholesterol, curcumin, and also what I just mentioned, the ketogenic diet. In animal models, there have been positive results, but there have been no good systematic studies so far. You can also, for patients with, especially for patients who have 2 copies of the PLP1 gene, so too much PLP protein, which is not good for the oligodendrocytes, try to decrease gene doses with this very specific medication. That's a kind of DNA-like molecule, and we call that antisense nucleotides. And you can, in animals at least, you can dose that so that you get normal amounts of PLP1. So you get the normal situation. And that's something interesting, which is also being studied by Jonas. And then there was a test of other pathogenetic mechanisms in PMD, and that's was a bit of a surprise, because in a study of PMD cells, there were changes in proteins involved in iron metabolism. And gene correction normalized these changes, and treatment with a medication which captures iron was successful in cell cultures of PMD oligodendrocytes and PMD mice. And we started actually a treatment trial of with those iron molecule, which had already been used for the treatment of certain blood disorders, leading to many blood transfusions. So the excess iron can be scavenged by those chelators. They are used in adults and children, but they have quite a few side effects: nausea, vomiting, diarrhea, which is not rare. And a rare side effect is a decrease of white blood cells. We call that leukopenia, and if you don't have any white blood cells anymore, you call that agranulocytosis. And that carries the risk of life-threatening bacterial infections. We have set up a study with a duration of 12 months of treatment with that deferriprona. We look at motor function as a primary outcome and myelination on brain MRI as a secondary outcome. We look for new biomarkers, and you need to do weekly capillary blood tests when the patient is at home, to look for this white blood cell problem. And if you see a problem there, you need to stop temporarily or permanently the medication. So you need to do a study to look really well at the real effects of this treatment. And you need to treat properly, not only 6 weeks, because that's really too short. We thought that a treatment duration of a year would be good to see the myelination changes. When you see how long motor development also takes in young children, you need to give that a little bit of time. So a treatment of 6 weeks or 3 months would be too short. We include patients with a severe form of PMD from the Netherlands or adjacent countries until the age of 8 years. And we had met some challenges. Not all patients could be started with the treatment right away because one patient had a low white blood cell count, so he was not allowed in the study at all. And 3 patients had a low blood iron, then need first iron treatment to boost iron levels, because otherwise you get problems with anemia, and we don't have results yet. There are other studies in PMD, a natural history study, where there are 4 sites in Europe, and where patients with PLP1 duplication are included. And within probably a few weeks, the follow-up study that starts, where antisense oligonucleotides are tested for patients with PMD with regular injections every 3 months into the cerebrospinal fluid, which was effective in the PMD mouse model. And again, that's aimed primarily at PMD patients with PLP1 duplications. So you see that there is something going on for Pelizaeus-Merzbacher disease, but I'm afraid we are not there yet. I would like to thank all patients and families, colleagues around the world, many others who help, and especially also ELA for their bringing together patients and researchers and all the work they do for raising funds. Thank you so much.
Thanks a lot, Nicole, for this presentation. Really nice. We will then hear Vivi Hein from Netherlands too, speaking about the 4H patient brain organoid to study disease mechanisms. Thanks, Vivi.
Thank you for the introduction. I assume you hear me well?
Yes.
Yes, that's great. Well, thank you first of all for the opportunity to present. It's nice to be here, and I will give an update on our laboratory experiments on 4H syndrome. And let me start by sharing my screen. Also, that I hope is good visible. Yeah, so I will, my expertise is in stem cell technologies and organoid cultures and the laboratory experiments. So I will give an update on our experiments that we do for 4H syndrome. And 4H leukodystrophy is one of the more prevalent leukodystrophies. And classically, it is characterized by hypomyelination, hypergonadotrophic hypogonadism, hypodontia. But other characteristics are cerebellar atrophy and myopia. But next to that, well, brain white matter dysfunctions are classically seen or thought to be involved in these patients. In recent years, it becomes more and more clear that some patients have more a prominent neuronal phenotype in the brain, such as neuronal changes in the caudate nucleus and in the putamen. So looking at the cause of 4H leukodystrophy, it is caused by mutations in genes such as POL3A, POLR3A, POLR3B, and POLR1C. And these genes are involved in the function of RNA polymerase 3. And Dr. Piquet already gave a very nice introduction on how DNA goes towards mRNA and protein, and these genes are especially involved in the synthesis of these small RNAs. And so it has a function in actually in all the of actually all the cell types in our body, but we still do not understand why the brain is so susceptible towards these mutations. So it is important that we better understand how these mutations actually will lead to the brain dysfunctions, and to get more insight for that, which is important to develop new treatment strategies, we quite often create disease models. And disease models that we are focusing on are is using the technology induced pluripotent stem cell technology. It's also called iPSC technology. And this technology gives the opportunity to generate embryonic stem cell-like cells from skin or blood cells or other cells from the body. And these iPSCs have the same capabilities as embryonic stem cells. And that means that these very early stem cells, that they can still differentiate into any cell type of the body. So we can now create very early stem cells from every individual and study how the genetic makeup and also mutations that are causing diseases, how that is actually affecting the development of tissue-specific cells, and we focus on brain cells. So the brain consists of many different cell types. It's already mentioned, like neurons, glia cells, oligodendrocytes that are producing myelin structures. And over the years, a lot of different protocols have been developed to generate all these specific cell types, and this field is still ongoing. And in the beginning, there was a lot of focus on creating monocultures, so more pure cultures, but over the years, also more and more co-cultures, neuron-glia interaction cultures, but also organoid structures have been generated. So we can generate, once again, from every individual, from blood or from skin cells, these early stem cells. And then in a cell culture dish, we can transform these early stem cells towards, for example, these three-dimensional brain organoid structures. So these organoids or organoids of other structures, these are cultures that spontaneously develop into complex cellular structures that also have some characteristics of and architectural features of the, let's say, the in vivo or the physiological organ system. And that's a kind of a process via self-organization. These organoid structures, you can actually see them even in the cell culture dish. So I also will show some examples in the next slide. And maybe it's good to realize it's not that we have a, let's say, a small brain in the cell culture dish, but it is either that the three-dimensional structure is mimicking more the forebrain or the midbrain or the cerebellum, or maybe even some other structures of the brain. So these are more complex local structures that we can create, and either mimicking more early or late developmental stages. So there are a lot of different cultures there. They generally also take a lot of time. So also here you see in this scheme that in this time, this time table, that cultures could be easily kept to day 150. But there are also other labs that have been keeping their cultures for even longer and longer than a year. So that's also typical for these organoid structures. We are studying 4H syndrome also as part of a European consortium together with other researchers who are focusing more on other leukodystrophies. And so here you see in this presentation the different researchers that are collaborating with us, and they focus also on global cell leukodystrophy and Canavan disease. And I will mention our studies that we are doing together. So here's the list of the donors. So all the samples and the cultures that we are created. So the samples are collected from different patients and different healthy donors, and also coming from different places from Europe, as you can see here on the right. So we created organoid structures, brain organoids, from all these individuals, and we have been studying these organoids at differentiation day 50, differentiation day 100, and 150. And we studied them with microscopy, fluorescent microscopy, which gives the opportunity to specifically look at certain cell types, if certain cell types are present, in what kind of maturation stage they are. We can quantify the numbers. We also did electron microscopy, and that is a way of looking at the cellular structure at a more detailed level. So we can study more the subcellular structures, such as myelin structures. And Professor Wolf already nicely showed those myelin sheets and how they can actually change if a patient is affected or the white matter is affected. And we also study these organoid structure by single-cell RNA sequencing, and that I will explain a little bit further in the following slides. So here you can actually see some organoid structures. So they are a little bit, those here, those black dots, but that is just the light of the microscope. But you actually can see them floating in your cell culture dish. And in the beginning, we actually keep those organoid structures separately in separate dishes, so we really can help them to mature as good as possible into a three-dimensional structure. But when they form a nice organoid structure, then we actually pull the organoid structures from one individual together, and then we keep them up to day 150, for example. So we study them at different levels. So here what we, for example, did is checking the growth. So during culturing, we actually measured the size of the organoid structures. And you also see that we did that not for 4H, but also for the two other leukodystrophies and also for the healthy donors. And there's actually no significant change between these patient lines and the controls, and that's also not directly what we expected, but this is also a way to check whether the cultures are actually healthy. When we collect the organoid structures, we fix the organoid structure, so then we actually preserve the protein content, so we can actually visualize it later on. At the beginning, these are still three-dimensional structures, but then we make very thin slices so that we can also analyze them under the microscope. And here I'm showing some examples of how we labeled specific cells with OLIC2, which is a marker for oligodendrocytes. It's already coming up pretty early, so they could be maturing or mature oligodendrocytes. MBP stands for myelin basic protein, and if MBP is present in the oligodendrocytes, that is indicating that they are starting to form myelin structures. And NF200, that is a marker for neurons, and it was already mentioned before that neurofilament, for example, could be detected in blood as a biomarker. This is actually a marker that is indeed in the brain, is used to identify these axonal structures of the neurons. So this gives a way of looking at our organoid structure and quantifying the cells and see how different structures are changing. It also gives the opportunity to count the number of cells. So you have once again, you have all those donors, the different organoid structures. We counted in different sections the number of OLIC2 positive cells and MBP positive cells. We do not immediately see a difference here yet, so we need to look at further. But what you, for example, nicely can see if you compare the organoid structures between day 150 and day 100, then you really see that the organoid structures are maturing and that the oligodendrocytes start to express myelin basic protein. And that is what you would expect when they are maturing. So the cultures look healthy, and we are and they are, let's say ready to study them in more depth. And one of the tools and analysis types that we using now is the single cell RNA sequencing. And maybe it's good to take a little bit of time to explain this. So in the past, what we did is, if we wanted to see like what genes are actually active in the cell, what is the transcriptome, as Dr. Piquet nicely explained, once again from DNA and RNA, and that RNA is then translated towards protein. So in the past, we quite often were taking the whole structure, the whole tissue, and break down all the cells, and then studied the transcripts. However, organoid structures or different other more heterogeneous or complex structures have different cell types. So there could be specific genes and transcripts that are only changed in a subset of cells. And that might be very important to identify, because that could give insight in how certain disease mechanisms develop over time. So maybe it's really some cell types, specific cell types that show a certain change that will trigger other things in the more complex structures. And in that sense, the single cell RNA sequencing approach is very powerful. So we take the organoid structures, first create single cells, and then from every cell, we, let's say, barcode the transcript, so we can actually later recognize the transcripts and see to what cell they actually belong to. And we create a transcript profile from every cell. And as I said before, the brain and also these organoid structures, they contain a lot of different neural cell types, from stem cells to glia cells, more mature oligodendrocytes. And it is also a maturing structure. So it is, so you probably can imagine that you have a lot of different developmental stages present in your organoid structure. So that is also making it in a way a little bit complex to let's say label those different profiles from those single cells. So so this is a typical image that you're getting out of, let's say, the machine if you did some RNA single cell RNA profiling. So here on the left you see a two-dimensional plot of all small black dots, and every black dot is representing one cell with one expression profile. And if those dots are closer together, then those cells also have an expression profile that is more similar. And while the dots are more apart, then the expression profile is not very alike, and then they are probably very different cell types. So programs can also give automatically create these clusters. So that is done on the right side. So based on how close certain dots are together, the machine is, and the software is saying you probably that cluster of cell that is representing one particular neural cell type. So here you have another representation of the same. And what we did here, now every cluster, it is a different scatter plot, but it's the same idea. So now every cluster actually got a label of a certain cell type. And that labeling, that is what we are doing ourselves. So that is a little, let's say, a little bit biased. And how do we do this? So we know already that some genes are expressed in neurons or oligodendrocytes. So for example, OD2, MBP, we know those genes are expressed in oligodendrocytes. So if we see those genes back in those particular groups, then we can start labeling these different groups. But as you can see, in the end, so we had to do a lot of, let's say, labeling based on known gene expression for the different cell types to eventually create these different clusters. Well, and then at the moment you have these different clusters, then we can take the next step and saying like, okay, now we have these different clusters from controls and from the patients, and now we can dive in to see how those single cells are change in expression profile, unknown gene changes that we have not identified before that could be related to 4H or the other leukodystrophies that we studied. It also gives the opportunity to do a very nice quantitative count because we have all those dots and we labeled them all in groups so we can count, or the machine, the software can count those different dots. So we can also nicely see like actually how many cells are actually present. So how many oligodendrocytes or proliferating oligodendrocytes or astrocytes in those different donors. And we can, and here that's just an example of the glia cells, but we also have that for the neurons. And this is a really, let's say, an upscaling from what you can do with immunocytochemistry, what I did before, that you really use certain antibodies to label certain cells. But here, after doing all the preparing work, you can actually in the end do a lot of counting. So focusing a little bit of 4H, we're still in the middle of analyzing, but just to give you a hint of how we look at these plots. So this is just control versus 4H, and we collected samples at day 100 and day 150. And what you, for example, can see between these two time points, and I indicated that a little bit with those with those lines here. So here, this blue block, those are the immature neurons. And you also expect that those neurons are maturing over time. And indeed, when you quantify, or when we quantify the number of neurons and immature neurons, so that is indeed decreasing over time. And the other way around is for the oligodendrocytes, so that is smaller in the beginning, but that group is increasing when you're at a later time point. So we can actually study those different cell populations at different time points. So now what we currently are doing, and I'm giving just two examples, is that we have these different cell populations, we labeled them, and now we want to see what are actually genes that are changed in these populations or different between the healthy donors and the 4H, gene changes that we were not aware of before. So that is what we want to look into. So there, and indeed we see all kind of gene changes. So these are the upregulated genes, and here in green are the downregulated genes. And we have a lot of different plots because we have a lot of different cell types. We have plots at day 100, day 150, and now we can start seeing like, hey, do we see similar changes in different cell types? Is it how is it over time? Is it very unique to 4H, or do we see also changes in the other leukodystrophies? So maybe it's more general for the different leukodystrophies, and that we can look at the gene level. Here's another plot, but we can also look at the pathway level, so that we can grab a little bit the different gene changes together, and we know from a lot of genes what they are doing, also from a lot not, but at least we can group, if we can see like a lot of genes that are involved, for example, up here in signaling by NTRKs, then that is a higher likelihood that, for example, maybe there's something involved in those pathways in 4H. And that is currently what we're studying. So we do not have a definite answer yet. So there's a lot of data and a lot of opportunity now to look and study the data at different levels. So hopefully I gave you a little bit of an insight in single-cell RNA sequencing, what we're currently studying. So what I presented is that we have a kind of a brain organoid research platform for leukodystrophies. We focus on Canavan, GLD, and 4H. And of course, our interest is mainly 4H, but in the future, it's also the wish to include other leukodystrophies. It gives the opportunity to dive in to study how genetic changes are influencing different cell types outside the body. And the single-cell RNA sequencing is actually quite a powerful method to look at really different cell types. And my last slide is to really acknowledge all the people that contributed to these studies, and of course all the funders and ELA who give the opportunity that we actually can do this work. Thank you for your attention and listening.
Thanks a lot, Vivi, for this nice presentation. We will then shift to our fourth presenter, sorry, which is Geneviève Bernard from Canada. And we will speak about RNA polymerase III related hypomyelinating leukodystrophy.
Hi, can you hear me well?
Yes.
It's great. Thank you for the kind introduction. I am going to share my screen. And you see the right screen, eh? Not the presenter screen. Okay. So I'm very happy to be here. Thank you for inviting me. I'm going to speak English because I think it's easier for the translator, but I'm happy to answer any questions in French if need be. So I'm going to talk about the work we do on 4H leukodystrophy in my lab, or also called RNA polymerase III related leukodystrophy. So these are my disclosures. I've done some consultancy for some companies. I also am a site PI or sub-I on several clinical trials, but none of these are related to 4H. So polar III related leukodystrophy is also known as 4H leukodystrophy. It was very nicely introduced by Dr. Hein before. So the 4 H's stands for hypomyelination, hypodontia, and hypogonadotropic hypogonadism. It is an autosomal recessive disease, and Dr. Piguet explained all this earlier, but just as a reminder, in an autosomal recessive disease, every child has a mutation in both of the copy of their gene, and parents are carrier, so they have only one copy of the mutated gene, and therefore they're healthy. It is caused by mutations in genes encoding subunit of the RNA polymerase III. So far, there has been polar IIIA, polar IIIB, polar 1C, polar 3D, and polar 3K that have been related to 4H leukodystrophy, and some other subunits such as the 3GL, which is associated with other phenotypes. The RNA polymerase III is responsible for transcription of small non-coding RNA that are important for cellular homeostasis. And specifically important for translation from DNA to translation from RNA to proteins. So this is a disorder that typically presents in early childhood, but earlier presentations are possible and later presentation as well. And the patients have a combination of both neurological and non-neurological manifestations. The neurological manifestations are due to hypomyelination. So like Pelizaeus-Merzbacher disease, this is a hypomyelinating leukodystrophy. What predominates in these patients is the cerebellar features. So the balance difficulties while walking, sometimes there's a tremor, and then the articulation difficulties, the slurred speech. There are also what we call pyramidal and extrapyramidal features, which are stiffness, but usually they're not as prominent as the cerebellar manifestation. And also the vast majority of patients also have cognitive disabilities, including learning disabilities, intellectual disabilities, and in some patients, cognitive regression. The most common, I think, non-neurological features is myopia. So most patients have myopia, and it typically progresses over several years and becomes severe. So it's important for these patients to be followed by an ophthalmologist regularly and have their glasses adjusted. Most patients have typical facial features, and the hypodontia is possible, but other dental abnormalities are also seen in these patients. Hypogonadotropic hypogonadism is it are two long words to say delayed, absent, or arrested puberty. So patients may not have a normal puberty, and other endocrine manifestations are also possible. Not all patients have the non-neurological features. They can have some, but not others. after we found the initial genes, then we realized that the spectrum of the disease, it was much wider than initially anticipated. Okay, so this is the typical presentation. Toddler with motor delay, motor regression, clumsiness while walking. We had initially also older patient who presented at school age with some learning difficulties and less motor difficulties. And then over time, we also found a subgroup of patients with specific mutations in POLR3A who had a very severe presentation in the first 2 to 3 months of life, with severe developmental delay, regression, difficulty swallowing, difficulty gaining weight, and rapid progression and unfortunately early death. But we've also found over the years some patients that had hypomyelination that was milder than others, and that were either asymptomatic, so the patients were that had an MRI for another reason, and found to have hypomyelination, and then when worked up were found to have 4H, or very mildly symptomatic, and that's with a specific POLR3B mutation that we've seen those patients. But the disease spectrum continued to expand, so we realized that not all patients have hypomyelination. Some patients have have a very similar clinical presentation, but one has hypomyelination and the other doesn't. So there's still a lot to understand as to why this is happening. Some patients have only spastic paresis, so stiffness in the legs, spastic ataxia, so stiffness in the legs, but also clumsiness and difficulty with balance when walking. As I said, there are patients that have basal ganglia involvement, the mild striatal form and the severe striatal form, so no hypomyelination, but abnormalities in the basal ganglia. There is an early aging syndrome that's also been shown to be caused by mutations in POLR3 genes. There are patients that have only the endocrine manifestations. There are patients that have only bone manifestations. There are POLR1C is also a gene that causes Treacher-Collins syndrome. And some patients have only Treacher-Collins syndrome. Others have Treacher-Collins syndrome plus 4H with mutation in that gene. And more recently, the autosomal dominant, so de novo mutation, so only one copy of a specific group of mutations in POLR3B lead to a completely different phenotype of ataxia, spasticity, and neuropathy, and in some patients, epilepsy as well. So still a lot to understand. So the first question that we asked ourselves is, what's the impact of these variants that cause disease on the POL3 complex, the RNA polymerase 3 complex and function? And then won't go through all the results in detail, but the conclusion was that either you have less of a subunit, so subunits, the RNA polymerase 3 is 17 subunit, and it has to build together. So some mutation lead to an abnormal building of the entire 17 subunit complex, which is important, which is important that it's together to do its function of transcription. And then some mutations are thought to alter the interaction of the 17 subunit complex with the DNA to do the transcription. And ultimately, us and others have shown that there is a reduced amount of what is supposed to be transcribed by POL3, sorry, and those transcripts are important for cellular homeostasis. So then we wanted to know why patients, we wanted to study further why patients had hypomyelination. So we did some in vitro and in vivo studies. So the oligodendrocytes, as you probably all know already, are the myelinating cells of the central nervous system. And myelination is a process that starts in utero and progresses until adulthood, but around 2 years of age, almost the brain is almost completely myelinated. So it is a process that is occurs mainly in a very short period of time. And so we believe our general pathophysiological hypothesis for this disorder was that if you can't transcribe enough because your pol3 complex is not working well enough, then the oligodendrocytes are not able to myelinate the entire brain. So we started our experiment based on this. The first part of the experiments I'll show you were mainly done by Julia McIntosh, which was a master's student in the lab, who is now a PhD student working on another disease. So what you have to know about oligodendrocytes is that they have to migrate to where they will myelinate. They also have to proliferate, and then they have to maturate, so becoming from oligodendrocyte progenitor cell, the baby oligodendrocytes, if you want to measure oligodendrocytes, which have a different, they have more branches to them, and then they have to myelinate. So we wanted to address whether or not where we thought these the problems would be on these different developmental stage of the oligodendrocytes. So what we did is we used normal, like healthy mouse brains, and then we isolated the oligodendrocyte progenitor cells, and then we studied we used different studies to look at migration, proliferation, differentiation, and myelination of these cells. Sorry, and I forgot this step. So we did we isolated the OPC, and then we used we knocked down the different subunit, polar 3A, polar 3B, and polar 1C, which means that we made less of the RNA, so less of the protein, so that there would be less of the pol3 transcription. And so in brief, what we've shown is that, so there was some proliferation abnormalities, but what was the most interesting to us is that there was a maturation block. So the oligodendrocyte were not able to be, the OPC were not able to become mature oligodendrocytes, and then the myelination was also affected. So some of in vivo study that we've done in the lab, mainly by Michel Robinson, who is an MD PhD student in the lab. So there's different types of mutations that we have seen that earlier this afternoon. So a missense, which is a typo, so a change in one letter, a knockout, which is a different, it could be a typo, but leads to absolutely no protein produced, a deletion, so some missing letters, and other mutations. So you can do mouse models with different types of mutations. And then there's different types of mouse model you can do. So the ideal mouse model would be a constitutive mouse model, so where the entire mouse has the mutation. A conditional mouse is a mouse where you put the mutation in specific cells, and an inducible mouse is a mouse where you trigger the mutation at a specific time. And the goal is always to have a model that's the most representative possible from the disease that you're studying. So prior to the work we did in our lab, it has been shown that the homozygous knockout mouse, so the no protein on a mutation that produce no proteins on both copy of the gene, are embryonic lethal, so do not produce live in mice. And then if you have a human mutation that you put on both copies, or a human mutation with a stop on the other allele, there is no phenotype, or the mouse was embryonic lethal. So there's a group, the group of Ian Willis, who did a polar 3A conditional mouse model with 2 contiguous polar 3A mutations. So 4 mutations, basically, 2 on both alleles, and had a neurobehavioral phenotype with impaired myelination, so a very nice mouse model. We decided to do a polar 3B mouse model, and our approach was to use a mutation that have a deletion of exon 10, and we did an inducible conditional model. So we put the mutation only in the OPCs and related cells using a specific Cre driver, and we injected tamoxifen to induce the mutation when the oligodendrocyte progenitor cells are proliferating. So this is just a cartoon showing that this is in Polar Tree B. We deleted exon 10, and then we looked in human cells what this deletion of exon 10 would do, and it does lead to a severe complex assembly defect. So we were quite happy with that, because that's one of the mechanisms that we talked about that we know happens with some human mutation, because this is not a human mutation, but still. The mouse has hypomyelination, so the green is the myelin basic protein. So you can see that there is less green here than here, and same for here compared to here. And then when we did further studies, we've shown that there was decreased oligodendrocyte progenitor cell proliferation, maturation, and survival. So again, we were quite happy with that. The mouse had a very severe neurological manifestation with tremor, ataxia, seizures, neurodegeneration, and early death. So this is that was a good model for us, because it will allow us to try potential therapies and to see an impact relatively quickly, because the mouse has a severe phenotype. And then the mouse is also small. I didn't mention it, but about half of the patients also have small statures. So that was also something that we were happy about. The mouse has dental abnormalities. So if you can see here, the teeth are not, they're either absent or they're smaller compared to the healthy mice. And they also have craniofacial abnormalities, which is something that we also see in patients. So we were quite happy with the phenotype, which represents very well what we see in patients, and hopeful that we would use this mouse model to study therapies, new therapies. So I wanted to acknowledge all patients and their families, all collaborators around the world, and the clinical work that we've done on 4-H. I've been done very closely with Nicole Wolf and Adeline van der Veer, and we have collaborators all over the world helping us with the functional studies that we see. And as you can see, my team is expanding, and I thank them all for all their hard work on leukodystrophies. And over the years, we've received funds from different organizations for our work on leukodystrophy. So I'm very grateful for that as well. And I'll take any questions.
Thanks a lot, Geneviève, for this presentation. We will now go to our last presenter, who is Pedro Brites from Portugal, and we will speak about myelin defect caused by a deficiency in SLC44A1, the cholinergic-transporter-like one.
Hi, good afternoon, everyone. Can you all hear me?
Yes.
And can you see the presentation?
Yes, for now it's still in the, let's say, PowerPoint. Maybe you can put like as large. Perfect.
Okay. Hi, everyone. I also like to start by thanking the organizers for the invitation and for the opportunity to present the work that we're developing on this new leukodystrophy caused by mutations on this gene called SLC44A1. And this was a very recent discovery that mutations in this gene, the SLC44A1, cause a severe human disorder characterized by progressive ataxia, tremors, cognitive decline, dysphagia, optic nerve atrophy, and also white matter changes, as you can see here by the MRI images that were described in the manuscript. I'll just put here the laser on so I can point. So this was initially described in 2020, although the gene has been known for many years as a protein that was encoded for a choline transporter-like one protein. Currently, and up until the discovery of this disorder, the only cellular model that was available were cultured skin fibroblasts derived from patients. And as I said, SLC44A1 was also called the choline transporter-like 1 receptor, which at the time predict an involvement of choline or choline transport in this disease. And at the time, this fit with the literature, as the choline is a vitamin-like essential nutrient that all cells require. And because of its cationic nature, it requires an active transport across membranes, so it requires the transporters to do it. And it's important for the synthesis of phospholipids, the synthesis of acetylcholine, and also the synthesis of betaine. Although there were many transporters already known, SLC4041 was belonging to this large family of SLC44 proteins, which were predicted to be choline transporter-like proteins. They had relatively high affinity, and they were sodium independent in the manner of transporting choline in vitro studies. But because of this necessity of the ability of only having fibroblasts as a model system, we initiated the development of mouse models for this disease. And we used the CRISPR-Cas9, which is, of course, the state-of-the-art technique nowadays to generate mouse models. And we generated at the same time the knockout, in which we deleted exon 5 from the SLC4041 loci. And this causes a mutation, a nonsense mutation, very similar to a human variant that has been described in a family of patients. At the same time, we also generated the conditional allele, which is an allele that is fluxed by LOXP sites, in which we could be able to generate cell-specific or tissue-specific mutants, depending on the CRE line that is expressed. And our initial characterization of this mouse, what it revealed was that the knockout allele is a null allele. So using cDNA analysis in brain, what we observed is that there are no mRNAs containing the exon 5, and this was done using primers on exon 4 and on exon 5. But moreover, what we observed using primers flanking exon 4 and 6 is that even the mutant allele is hardly expressed. So this is most likely caused by nonsense mRNA decay. But combining that this this mutant is a null allele, so there's almost no mRNA produced and no functional protein is being produced. The surprising observation that we did early on was that although we had a full knockout for SLC4041, this had a very limited impact on choline levels in brain. So when we measure choline levels in brain, there was a marginal reduction in choline, but we also used fibroblasts derived from wild type and knockout mice, and we assayed choline transport using a choline analog. And if cells transport choline, this choline analog becomes fluorescently red. And as you can see here also by the quantifications, transport after 2 hours or 4 hours, transport of this analog is completely normal in the mutant cells compared to the wild type cells. So there's no specific defect in choline transport. And of course, while we're doing this, almost a year ago, in June 2023, it was discovered that there are 2 other genes, the FLVCR1 and the VCR2, which actually encode the general transporters for choline in mammalian cells. Both of these proteins function as a true transporter in which they transport choline, but the authors of these papers also show that if you overexpress SLC4041, which is this second gene in here, this has a minimal impact on choline transport. So we're in a situation that we have a human disease caused by mutations in SLC4041, which was originally attributed to the function of the transport of choline, but now it has a minimum impact in choline, and so it should be causing additional defects. And of course, the main questions that we now face are what is the function of SLC4041, and what is the impact of SLC4041 deficiency in the central nervous system, in the CNS. And our approach to solve this is to generate mouse models, as I showed you in the previous slides. And then with these mouse models, we'll study the biochemistry, the cell biology, determine the mechanisms of disease, and then also use them to develop preclinical therapies that then can be used to translate back to patients. And the mouse model, I'll just show you some slides showing that the mouse model actually mimics the human disease. The mouse develops an ataxia early on. As you can see, this is the paw clasping assay, in which you see impaired reflexes. Normally, when a wild-type mouse is hanged by its tail, it just plays the paws. In the mutant, you get this clasping of the hind paws, and this is a phenotype that is observed early on from 2 months of age, but is also present on animals at 1 year of age. The mice also show abnormal coordination. As you can see, we put them walking here on this ladder step, and a wild-type mouse is able to place the paws correctly on each of the metal grids. In the knockout, the knockout fails to have this coordinative movement and has these paw slips. And this is also a phenotype that you can detect early on at 2 months of age, but is also present at 6 months of age. So there is an ataxic-like presentation with both abnormal reflexes and abnormal coordination. As a general assay to see if something is wrong in the CNS, we also showed that there is astrocytosis, so astrocytes become activated upon the deletion of SLC4041. As you can see here, this is on 1-year-old mice, both in the cortex and the medulla. Here with the corpus callosum, the cortex and the hippocampus. You can see it when comparing the wild type with the SLC4041 knockout. There's a massive upregulation of the marker for astrocytes GFAP. Here for the quantifications, but also by Western blot, you can actually see that there is an upregulation of GFAP. So there is an astrocytic response to the disorder. But of course, the most striking pathology was related to the myelination and the myelin. And what I'm showing you are just images of electron microscopy images of the optic nerve of wild type and mutant mice. And what we observed was that compared to the wild type on these EM images, as you can see, there's the axon in the middle with its organelles and its cytoskeleton surrounded by this dark layer of myelin. In the mutant, what we observe is that there is the generation of this what is called myelin outfoldings, in which there's this extra tongue of myelin that starts to grow sideways from the main axonal fiber concentrical myelin deposition. And this is also detected early on from around 2 or 3 months of age. It's present also in very old animals, which are these panels here. And what you can see in here, and these ones, they were pseudo-colored, so you can actually detect individual ones, is that with age, there's this progressive growth of the outfolding that can either wrap itself around the structure or can just travel throughout the parenchyma of the central nervous system. And you have multiple axons here, the ones labeled in green, blue, red, pink, and the brown, indicating that it's an overwhelming event present in the parenchyma. Sorry, this is in the optic nerve. What we also observed is that I'm not showing is that in addition to having these myelin outfoldings, there is a decrease in the G ratio. So there is less myelin around each individual axon. But what is surprising is that with age and because of the outfoldings are extending throughout the lifetime of the animals, we get this accumulation of myelin markers like MBP, MAG, GST-PI1 or TTP1, which just is just an indication that in time there is this progressive increased production of the outfoldings that just contributes to more and more myelin being produced to contribute to this phenotype. Of course, at the time that we started this, we also did not know that there were additional receptors. What we've shown in the first years of the research that we did this was that a high choline treatment is not a good therapy for this disease, because as you can see here, this is a knockout on a low choline diet This is a knockout on a high choline diet. And again, this is the optic nerve. And what you can see, both comparing the low with the high choline, that even on the high choline diet, there are massive myelin outfoldings present throughout the optic nerve, meaning that a choline treatment will not be a possibility, as it was originally proposed in the 2020 paper describing this disorder. What we also will show is that this defect is specific to oligodendrocytes, because we use the conditional mutant to generate an oligodendrocyte specific mutant, and we use this by crossing the floxed SLC4041 mice with the CNP-CRE, and this causes a specific loss of SLC4041 in oligodendrocytes. And then again here, what you see is our 2 electron microscopy images of the wild type. So this is with the normal gene, and then this is with SLC4041 deficient only in oligodendrocytes. And as you can see, is that even at 1 month of age, there's already massive outfoldings. And again, here each outfolding is pseudo-color on a different color, and you can see that there is these protrusions of myelin running around in the optic nerves of the mutant mice, suggesting that just the deletion of SLC4041 in oligodendrocytes is able to cause a leukodystrophy in these mutant mice. So to summarize, we generated a valid model for this disorder. The mouse model mimics key aspects of the disease, including the ataxia, the optic nerve pathology, and myelin involvement. And of course, we have been using these animals to tackle the challenges ahead for the SLC4041 deficiency. And I just listed here 2 of them. One of them is to know which effectors mediate the myelin defects, meaning what are the proteins that they are causing and that compose the basis of the disorder. And we're doing this using house proteomics, in which we're comparing the proteome of SLC4041 mice with the myelin-specific mutants. But we're also, of course, interested in understanding the function of SLC4041, as it's supposed as it has a structure to be a transporter, and we're using lipidomics to characterize the lipidome of these mutant mice to see if there is a defect in a metabolite that can explain the disease. And then finally, I'd also like to thank the people involved in this project that was granted by ILA, Tiago Silva, Mariana Ribeiro, and Mateus Correia that are actively working on the project. And this, of course, was also done with the help of the admin facility at I3S. I'd like to thank you for your attention.